listening
to Radio Lab.
Radio
From
WNYC.
Hey, I'm London Faster. This is Radio Lab. And today I want to share a conversation that I had with a guy named David Faigenbaum. He's a doctor and a professor at the University of Pennsylvania. And there's a combination of reasons why I think his personal story is so extraordinary and why I wanted to share it with you. Part of it is this staggering series of crises that he faced in his personal life, starting when he was in university. Part of it is kind of his personality, like what there was in him that made him stand up to these crises in a really particular way. And part of it is the way that he took his response to those crises, and now he's scaling it up using one of the most controversial technologies around, AI. The result of all of this is that he is right now in the middle of doing something wildly ambitious, something I find kind of miraculous, also maybe troubling. Either way, it is definitely going to change the medical system, down to the level of the pills that you put in your mouth. That said, I just found my conversation with David so fascinating, and his personal backstory in general, I found it so dramatic that I wanted to let it unfold at its own pace without jumping too quickly to the end. So here we go.
Latif?
Hey!
How's it going?
Oh my God, it's great. How you doing?
Doing good. We've got double mics here. I've got a friend who's here helping with
Nice.
helping with the audio. So we're double mic'd right now.
Great. So, are we good to begin?
Sure.
Okay, let's begin with the beast. Tell me, who is the beast, and what is the beast, and where did the beast start?
I don't know if I've ever answered a question this way, but when I was in medical school, I worked out all the time, and part of that was because for the previous 15 years of my life, I was obsessed with wanting to be a college quarterback. And
why? Why was it? Why was that the thing?
You know, it's so I grew up in Raleigh, North Carolina, where college sports are really big, and NC State had a football team, and I grew up sort of like loving their team. But I think maybe more than anything is once I started playing football and I started I'm biased, but I think football is unique among team sports in that you connect with your teammates in such a way, because literally like your health and your life is like on the line if someone else doesn't do the thing to protect
Especially
you,
as a
or you don't
quarterback,
do the thing to protect them. As a quarterback,
Right.
yes. And so I just fell in love with football as a kid. I mean, as a kid, I just was in love with it. If you could have seen my walls when I was growing up, literally every corner of every wall in my bedroom was covered with charts measuring like how far I could throw a football, how fast I could run, all with the goal of getting better.
But you actually get your dream.
I get my dream. I get this opportunity to go to Georgetown to play football, and it was the dream where it was like, okay, I can go to a great university that has a health science program, so I can keep studying health science, and I can play football. I really love the coaches there. But then, I got to school, and I was there for only a couple weeks before I got this just horribly devastating call. My dad called and said, "David, your mom has brain cancer. You need to come home right away." So I immediately went back home to Raleigh. I was able to just see my mom just before her brain surgery, and then we went to Duke for her brain surgery, and
what was the horizon of possibility here? Like, what did you think was going on? What did you think was possible?
Yeah, so before the brain surgery, they just said it's a brain tumor. It looks like it's brain cancer, but we need to go in there and actually see what it is. So my family and I, we were so nervous about everything, because they did warn us before that the person that comes out of surgery isn't always the person that goes into surgery.
Yeah.
And I remember going back to see my mom with my dad, my two older sisters, and she had this wrap around her head. She had a bandage around her head from where the tumor had been resected, and she had this bulb that was coming out of the incision site. It drains out fluid from the incision, and we were all so nervous. No one really knew what to say. I said, "Hey, Mom, how are you doing?" And she pointed up at her head with this bulb and the wrap around it, and she said, "Chiquita Banana Lady." which was like referring to like if you look at the sticker on your bananas, there's like there's the Chiquita Banana Lady. She has a wrap and she's got all the fruit. Her head kind of looked like the Chiquita Banana Lady, and like it was exactly what we needed. It was like exactly what we needed. Like we all burst out laughing and crying, and we're snot crying, and like our mom's with us. Like it just like that. Yeah, that's just
she's still herself.
She's still herself. That's who she was.
Yeah. What was the sort of prognosis after that, or what was the timeline?
Yes, the doctors came in and they explained that they explained it as grade 4 glioblastoma, which the average survival was around 6 months, and I think they said the longest someone had survived, I think I remember it was around 5 years. So I spent a few more days at home after surgery and just like would not leave her side.
And then how long did your mom last?
She lived 15 months after diagnosis. She was diagnosed July of 2003. She passed away October 26th of 2004. But while I was home, we had a lot of just really special time together. One of the things we did was actually go through old home videos. Like, we had these like Betamax videos. I don't know if you remember these like old home videos.
Totally.
Went through them and just, we did like all the things that you want to do. All the things that you'd want to do before someone like my mom passes, and this was 21 years ago. Did all those things, and it was really special. And it also, as you can even tell, this is 21 years later, it created such a drive in me to just say, yeah, I want revenge. I want to do whatever I can to take this thing on.
Yeah.
And I told her, I was like, Mom, I'm going to dedicate my life to trying to help people like you. Like, that's just like full stop. Like, this whole football thing, that was fun these last 8 years. But yeah, I'm going to be a doctor, and I'm going to dedicate my life to just find treatments for this horrible thing that was taking my mom from me.
Yeah. Okay, so now cut to, so you finish college, get into med school.
Yeah.
The same way that you were calorie counting and quizzing yourself on playbooks, like you're doing the same thing, except now cancer is the other team.
That's exactly right. And of course, the challenge in med school is it's very much a training period, which is hard for someone like me, right? It's like, I want to take this on. I want to make a difference, but I'm in this period where I've just got to train.
So you're doing that, and then at some point, okay. And so what happens?
So I'm on my OBGYN rotation, and just started noticing that I was more tired than I'd ever felt, and I sort of always was able to run on low amounts of sleep and lots of caffeine, but I was really, really tired, like this fatigue that I'd never felt before. And I remember sort of like trying to just like put it out of my mind, like whatever this is going to go away. And I went into the hospital to take this medical school exam, and I remember during the exam I was like dripping sweat head to toe, and then I was like, you've never felt like this before, something's going wrong. I also had noticed these bumps appearing on my body. They're called blood moles, and they're normal as you get older, but they are abnormal to appear rapidly. And it's like, as I was studying for this exam a couple days before, I like noticed these blood moles on my body. And so I actually handed in my exam, and I just walked down the hall to the emergency department in the same hospital that I was taking the exam in. And I just told them about my symptoms. They did blood work, and I had worked in that ER just a few months before, and doctors are usually really slow to come back, and it's like, things take a while,
right,
unless there's something really wrong, and they come back really quickly. The doctor came back really quickly, and he told me, he said, David, he said, your liver, your kidneys, your bone marrow, your heart, and your lungs are shutting down. We have to hospitalize you right away. And I was just
that's like the whole body. Like, what else is there in your body?
Yeah, there's like your brain's left, but like pretty soon that was gonna not be as clear.
Right.
But yeah, it's this concept called multiple organ system failure, where everything was shutting down, and so they hospitalized me, and I just went downhill from there. I started getting really sick really quickly, and I knew things were bad, and the doctors were using the language that I had used when I talked to patients when things were really bad. And
like, what were they saying exactly?
We've run a lot of tests, and we're on top of things, but we're not really in a position yet to tell you exactly what we think is happening. Right. And it took a total of about 11 weeks before we finally made the diagnosis. And with that diagnosis came almost immediate use of a type of chemotherapy.
Well, before we get there, so what was the diagnosis? What was?
Oh, yes,
yeah.
yes. the diagnosis was called idiopathic multicentric Castleman disease. Castleman disease describes a group of these rare diseases where basically your immune system attacks your organs for an unknown cause. We call it idiopathic because we don't know what the cause is.
And had you ever heard of that, like as a med student?
When I heard it the first time, I vaguely remembered, like, I think I've heard that once in med school. That's how rare it was. I was like third year med student, and I think I heard it once.
Yeah.
But definitely not, I definitely wasn't familiar with it.
Right. And was that you get the test done finally? Yeah. Can you talk about that moment?
Sure. Yeah. So we were like really happy that it wasn't cancer. Like, we were like, yes, like this is not cancer. You know, we thought it was lymphoma this whole time, and it's not. And then there was this, you know, really quick realization shortly thereafter that that my subtype of Castleman's, idiopathic multicentric Castleman disease, actually has a worse survival rate than lymphoma does, and that actually the thing that we were hoping it was not actually would have been better, thing that it turned out to be. And I was so sick when the diagnosis came in that the doctors told my family, we don't know if this medicine is going to work, but he's so sick that we don't think he's going to survive much longer. You should go ahead and say goodbye to him and prepare him for you know, for not being here. And so
you were awake and aware of that happening.
I don't know if I was mentally, I wasn't totally there, but I do have, you know, some memories, and those memories are the room being really dark, my family hugging me and crying, and they just started telling me all the things that I told my mom, right? Like, you know, what I meant to them, and, you know, we're reminiscing on old memories, and then I remember the priest coming in. I mean, of course, I'd never had my last rites read to me before, so it sort of like confirmed my biggest fears, which is that, like, this is going to kill me. But just a couple days before the priest had come in, the doctors had tried this one chemotherapy. It was the only chemotherapy they thought to try. Like, there actually are others they could have tried, but this was the one they tried. And amazingly, it just started to kick in really within days. And it didn't last long term. I relapsed about a month later, and it was a real roller coaster because, like, the euphoria that we all had when I was feeling better, and the hope that we had, and then just, you know, a few weeks later when it would come back, just the heartbreak. And that cycle happened a total of 5 times in 3.5 years, where I went from being, you know, totally, you know, critically ill in ICU to much better to then back again.
And what was the moment? Was there a moment where you kind of engaged, where you were like, okay, I need to sort of activate?
Oh yeah, that moment for me, I remember very vividly. It was May 12th of 2012. It was sort of, I mean, if I think back on my life in these moments, like the moment when I got the call from my dad that my mom had brain cancer, and the moment I was sitting in the hospital room and my doctor explained to me that the only drug that had ever been studied for my disease wasn't working, and that there was nothing else. Like, I was just searching for something, like, is there a gene or a protein or a cell or something that we might know about this thing? Like, give me something, like, begging for, like, some lead. And he just was clear, there's nothing. Like you are going to die from this disease. The chemotherapy is going to stop working, and there is nothing out there. That was when everything changed. Everything in me shifted. If I want to survive, like, if I want to spend more time with this girl beside me that I love, Caitlin, and I want to get married to her one day, I want to spend more time with my family, like, I've got to activate. And it was right around that time I was learning about how a drug that was being used for Castleman's was also working for other diseases. And I was like, wait a minute. There's a Castleman's drug working for other diseases. Is there anything somewhere? Maybe there's another drug for another disease that could work for me. Like, it just is sort of like this, like, very simple concept. And it frankly, it was the only path. It wasn't like I was like, oh, it would be great to do this or to do that. It was like, this was the only path, was to find an existing medicine. And that became just my central focus.
So what do you do? How do you even start that?
Yeah, so first thing I did is I went to my mentor, Arthur Rubenstein. He was the dean of the medical school before. He just retired. And so I went to him for advice and his support, and he said, David, I'll support you. And he's been amazing over these years. But I wanted to go to someone who sort of, like, could give me advice. I didn't know what I was doing.
So you're like, I need help. I need a team. I need people.
I need to build a team. Exactly. It was like, I don't know what I'm doing, but I need to build a team. So first went to Arthur. He came on board. The second task would be to understand what was going on in my blood and in my immune system and see if there was something that was already approved for another disease that could maybe be repurposed to treat me. And that's when I guess they did the equivalent of, covering my walls and poster boards for throwing the football, and it just became all encompassing. I got to find a drug for this disease. I remember turning to Gina, my sister, and saying, G, I need you to call UNC and Duke. I need you to get all my medical records, ship them to Philadelphia. I need you to get all the blood samples and lymph node samples at each of the hospitals. They need to be in Philly because I'm going to get out of here in a few weeks. When I get to Philly, like the clock's ticking. I need to get to work. And her and Caitlin just got to work. And a few weeks later, I was back in Philly, and the blood samples were there, the lymph node samples were there, the medical records were there. And it was all day, every day to try to find a drug.
And I presume at that moment too, you're like, and another flare is like right around the corner.
It's coming, exactly. Yeah, and Caitlin and
It's like a train coming.
It's a train, and it's hit me 5 times. There's no chance it's not coming back. It's coming, and I don't have another shot. And I had a really big date in front of me. May 24, 2014 was Caitlin and I's wedding day. We were engaged, and now we're talking January of 2014. So I had about 4 months between getting out of the hospital and making it to our wedding day.
Like if you last that long.
If I last that long.
Yeah.
Exactly.
Yeah. Okay. So what do you do?
So I thaw all those samples, and I started doing something called serum proteomics, where the idea is you measure 1,000 different things in your blood, or 1,000 analytes or proteins in your blood, and then we did something called pathway analyses, where we try to understand what are the signals in the blood that are coming from these proteins being up or down. I did something called flow cytometry to look to see which of my immune cells were turned off and turned on. And then cytokine panels where we measured these 13 different proteins and their changes in the blood. And what emerged was that my mTOR was in overdrive. And mTOR is a communication line your immune system uses to turn on, to turn off, to proliferate. And when I saw that result, I immediately remembered that there's a drug called sirolimus, the other name for it's rapamycin, that is really good at turning mTOR off. It's an mTOR inhibitor. So like I saw the result, and it's like mTOR is on, and I was like, oh my gosh, isn't there a great mTOR inhibitor?
Wait, rapamycin? That's the drug?
Rapamycin is the drug that saved my life.
Oh my god, we already did a story about rapamycin. I didn't even connect it in my head.
And I love that story. I listened to that story, and I love that story.
Oh.
And of course, it's found on the island of Rapa Nui. It was hidden in a freezer in Canada. Like
I connected mTOR, but I didn't connect that it was rapamycin. It was literally rapamycin.
Yeah.
So it's like you find in the tests of your blood and your lymph node and whatever, like it's like that is leading you to a problem, and then you're like, is there a drug that solves this problem? And you're like, oh, there's one drug right there.
That's exactly right. And so I told one of my doctors, and I went through all the data, and I just said, like, do you think that we should try this? Like, I know it's never been used before for Castleman's, but like, can we try it? Like, he's like, should we try it? And his thought process was like, probably it's about a 10 to 20% chance it could work, but it's a 0% chance if I don't take it. And I'm willing to take that risk. And so he said, yeah, I'll prescribe it. And
so you do it, and then what happens? You take it. It's a pill.
It's a pill. It's 3 pills. Well, at first I took 5 pills, and now it's 3 pills. But within a couple of days, I started to feel better, and the blood work started to get better more rapidly than it would have otherwise. But again, I still wasn't ready to say like this drug is working. And so for me, I was like, I'm not going to get my hopes up. It's going to be a test of time. Am I going to make it to my wedding day? Am I going to make it a year? Am I going to make it longer than that? And just 4 days ago marks 11 and a half years that I've been in remission on this drug. I mean, I almost died 5 times in 3.5 years before, and now it's 11 and a half without this disease coming back.
Wow.
Amazingly, it weakens my immune system in the right way so that I don't just attack my own organs.
Wow.
And I mean, the moment that I started thinking that drug was helping me, and knowing that it was, always there for something else, and then certainly as the time went on and I got to marry Caitlin, and then as the years have gone on, I've just gotten more and more obsessed with this idea, because I'm literally breathing and alive because of a drug that wasn't made for my disease. I just feel this tremendous sense of responsibility that like, hey, David, if you're going to get lucky enough to have one of these medicines help you, you sure as hell better spend the rest of your time trying to find as many more of these medicines to help other people.
What happens next is that this story moves from being a personal story about David finding his own medicine for his own disease, and thanks to some supercharged technology, it becomes a story about all medicines and all diseases, and the entire way we figure out which works for which. That's after the break.
Voice of America and Radio Free Europe are at risk of losing government funding. A journalist who spent time in a Russian prison for her work with it grapples with the fallout.
I'll be talking to the families of our imprisoned journalists these days. What am I gonna tell them? That their loved ones are imprisoned for nothing?
And this week's On the Media from WNYC.
This is Radio Lab. I'm Latif Nasser, and we are back with a conversation I had with Dr. David Fajgenbaum, who, after almost dying 5 times, started obsessively studying his own body, his own disease, to try to find a drug, any existing drug out there that might be able to help him. And he did. And after 3 years of being repeatedly at death's door, he's now been in remission for 11 years. After he found that cure, he turned his kind of monomaniacal mind, and not just that, his whole lab at the University of Pennsylvania, toward understanding his disease, Castleman's disease, hoping to do the same for other people who are suffering from it.
So that led us to then say, okay, we need to do more laboratory work. We need to start uncovering more pathways that might be important, more genes, more proteins that are important. And so we started getting really involved in that sort of laboratory work. And in parallel, the next probably big milestone to go from like, okay, we help someone else with my disease, was actually my uncle was diagnosed with angiosarcoma, which is a horrible form of cancer, the same week that my brother-in-law was diagnosed with ALS. I went down to Raleigh to be with my brother-in-law. Happened to be the same week my uncle got diagnosed with angiosarcoma, so I went with my uncle to his doctor's appointment, and the doctor explained, there are these 2 chemotherapies, and they'll give you a couple months to live, but they're going to stop working. And so I suggested that we start looking for drugs that can be repurposed. And his doctor explained like there isn't anything for angiosarcoma. I'm like, yeah, I know, but like there wasn't anything else for Castleman's, and like I'm here, maybe we can find something else for angiosarcoma. And that's when we came across a study that had been published.
And is that annoying? Like, are you annoying to them when you do that?
I'm so annoying to them. They're looking at me and they're like, your uncle has a terminal illness. The last thing he needs is for his nephew to tell him or me that there's a treatment out there that can help him. Like, that's not what he needs right now is what they're thinking. And in my mind, I'm like, are you kidding me? He's still here. He's still breathing. I just walked past the CVS, and last time I checked, there's 4,000 drugs in that CVS. And I know those 4,000 drugs haven't been tried for him. So until we tried all 4,000 drugs, you can't tell me there isn't a drug in there that can help him.
Okay.
And so we find a study that had been published 3 years earlier that basically says that 4 out of 5 people with my uncle's cancer have very high expression of something called PD-L1. I'm here saying, like, let's test his tumor for PD-L1. And the doctor says, I'm not going to test it because no one with angiosarcoma has ever been given a PD-1 inhibitor. I think there's like a less than 10% chance that this gene panel that you want to order for Michael is going to come out with anything helpful. And I hear less than 10%, and I'm like, that's great. Less than 10%? Like, you mean like 5%? He's like, yeah. I'm like, amazing. So you're telling me there's a 5% chance that this test is going to give us something that's going to keep him alive longer than 2 months? Amazing.
You're like the Dumb and Dumber guy.
So you're saying there's a chance.
That's right. Yeah. That's the guy. You're that guy.
Yes. And so I don't blame them because when you're a doctor and you do this 100 times and it works 1 in 100 times, that is frustrating. But when you're a patient and it helps you that 1 in 100 times, it's everything.
Yeah.
And so I got another doctor to order the test. So we get the test results back.
You are such an annoying patient relative.
I'm so annoying. I am. Yes.
Yeah. Okay.
So it comes back. Well, first I should say, I had him order 2 tests. The first of the test, it came back with nothing informative. He was totally right. And that was actually the expensive test. That was a test that cost $2,000. that came back with nothing useful. So I will totally give it to him. The inexpensive test that I wanted him to order came back 99% of his cancer cells were positive for PD-L1 expression. 99%, which
Wow.
is not a guarantee, but it is a high likelihood that therefore a drug that inhibits this might be useful. And we got Michael on this medicine, and April of this year marked 9 years that he's been in remission from his angiosarcoma.
Oh wow.
Other patients have been treated with this. Other doctors learned about this and started treating their patients. And it turns out about a third of people with this horrible cancer, previously uniformly fatal cancer, will respond really well to pembrolizumab, to this medicine. It's now standard of care for his form of cancer.
Is that standard of care?
It's now standard of care without ever doing a clinical trial. And that goes to show you, when you have a disease that's this bad, and you find a drug that works this well, you can change the paradigm for the disease for relatively, I mean, as close to $0 as humanly possible.
But like, why is it that everything is so like, it's like we almost have this idea of like lock and key, like this medicine does this thing for this drug and da 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 da. But then it's like, and then you're like, no, but this key works in this lock over here. Like, why is it that is that? Anyway, yeah, tell me there.
So the reason I think that our system is like this drug works for this disease is because in order to get a drug approved, a drug company has to develop a drug for a specific disease and submit it to the FDA for that disease. The FDA approves it for that disease. And if that drug company mentions a single word about that drug working in another disease, they will get fined billions of dollars for what's called off-label promotion. So when the FDA approves a drug, what they're really doing is they're approving a drug company to market a compound for a specific disease. And that company cannot market that compound for any other diseases until they come back to the FDA to get that change made. But every time a drug company does that, it costs lots and lots and lots of money. So they don't go after all the opportunities they have. But insurance companies and payers realize, well, if this drug that's approved for this one thing could also be useful in this other thing, it would be good for patients, shouldn't we allow doctors to prescribe things off-label? And so that's something that happens very commonly. About a quarter of all prescriptions in the U.S. are off-label.
No.
Yeah, so it's somewhere between 20 and 30% of all prescriptions written every day in the U.S. are off-label.
Are not for the reason they're supposed to be.
Yeah, exactly. So that includes examples like doxycycline for Lyme disease, where like every doctor in the world would be like, yes, use doxycycline for Lyme disease. But doxycycline's a cheap old generic antibiotic, so whoever made doxycycline 100 years ago, 30 years ago when people figured out it worked for Lyme disease, they aren't going to submit for a label change. And that gets into the other factor here, which is that once a drug becomes generic, whoever originally made the drug, they stop making money off of the drug because you have generic competition. You have multiple companies that make the identical drug, and the price plummets per pill. And so no one in our system makes any money off finding a new disease for that drug.
But why wouldn't, like you would think from the drug company's perspective, like that they would want to go to the FDA, get as many uses approved as possible, because then they could go out and say, this helps this helps that, this helps this helps that. Like you they would make their market as big as possible.
Except it's more complicated than that, because you can only sell a drug for one price, regardless of what disease you sell it for. It always has to be the same price. So what that means is that you have to pick the first disease that you get your drug approved in. You have to pick the optimal market for that drug, for the optimal price, because pricing is actually not based on the cost of the medicine. Pricing is based on the value for that disease. So the fewer competitors there are for a disease, the more expensive the drug. The rarer the disease, the more expensive the drug. There's all these factors that affect how expensive the drug is going to be. And you want to if you're a drug company, you have to maximize your profit. So you need to come up with the highest price for the highest number of people. But it might be that a low number of people at a higher price is better than a high number of people at a lower price. And so you can imagine it gets really complicated really quickly. And it's all about the first disease you get your approval in. So companies have to be really thoughtful and strategic to maximize their profits about what their first approval is. Once they get that first approval, now they have to remember that they can't change the price for the next disease. And so this is this horrible economic issue, which is just so depressing, because like on the other side of these economic issues are people suffering.
Okay, I wanna hear more about what you're doing now. You're like, amazing, this works for me. How does that then go to, oh no, wait a second, I'm not just doing this for my family. Like I can big this up.
Yeah, the next big milestone was early in the pandemic. I was actually driving down to Raleigh, North Carolina. I had my wife in the car, and I'm listening to the radio about this, pandemic. And I'm sitting there thinking, gosh, this involves the immune becoming activated and causing all these problems. And gosh, it's going to take us months or years to come up with new drugs. Like, I really wish there was a lab somewhere out there that was really good with inflammatory stuff and could repurpose drugs and could like direct drugs at this thing. And then I was like, oh, maybe we should do that. So we decided to create a program called the Corona Project, where basically we redirected my like 15-member lab to focus specifically on COVID. And early on, as you'll remember, there was a lot of drugs that were repurposed. Some worked, some didn't work, but there's a lot of repurposing. This is the first time we did like a very concerted effort to be like, what else is out there for this one disease? Very much informed by what we've done previously. And COVID, of course, there's lots of controversy about what worked and what didn't, but the two drugs that unquestionably worked incredibly well were dexamethasone and tocilizumab. They saved millions of lives, and they were, old drugs that have been around for a long time. And so that further got my wheels turning on like, what if we could create a system to automate what my little lab was doing for one disease, but we did it for all diseases and all drugs simultaneously. Wow. And thankfully, in parallel to those dreams, the field of machine learning, artificial intelligence has matured so much that we can actually do that.
Okay, so tell me about AI. How are you using AI to matchmake here? How did you think like, okay, this part of it can be done by AI, or this part of it, or whatever, that kind of
stuff? So in my case, you can think about this. We use what are called biomedical knowledge graphs, which are just sort of mapping out like every medical concept on a map. So you can imagine like if you have this giant wall, and every single gene, every disease, every protein, every pathway was put against the wall. So if we were to start with that concept and say, well, what do we do for me? Well, you'd find Castlemans on that wall. It would only be there in one place. You'd find Castlemans. And what you'd find is you'd find an edge or a line between Castlemans and activated T cells, because I discovered that T cells were activated in my disease. You'd find another line to mTOR activation, because I discovered that mTOR activation was really up in my particular immune cells. And then you would find a drug from T cell activation and mTOR activation to sirolimus.
Right, the drug.
Because sirolimus is able to inhibit mTOR activation, so they're able to inhibit these activated T cells. And so now within this giant graph of every disease, every gene, every protein, you would find Castlemans with lines or edges to these two concepts, and then lines or edges to sirolimus. And you would see a connection between them. And so now imagine doing that for every disease, every gene, every protein, basically what the world knows about all of medicine.
It's almost like mechanical what you're doing. It's like
it is.
It's like you're trying to make like the mechanical blueprint of what is going on.
That's exactly right. This leads to this, leads to this, and this reverses this, which reverses this, reverses that. Everything is right there. It's everything. Well, now what we do is we train machine learning algorithms on all of those known treatments. So like the sirolimus for Castlemans, sildenafil for pulmonary arterial hypertension, insulin for diabetes. Imagine training this algorithm, because machine learning algorithms are so good at finding patterns. And so we're giving the machine learning algorithm lots of information about known treatments. And we're saying, this is an example of when a drug works for a disease. And we do it thousands of times with all of the treatments that are out there for all the diseases that are out there. And then we say, okay, algorithm, now go and score how close of a pattern the connection is between a known treats relationship for every other drug versus every disease. So if a toenail fungus drug looks like there's no way it could work for pancreatic cancer, you need to give it as close to a 0 as possible, 0.0001, right?
Right.
But if leucovorin looks really promising for a subtype of autism, because the pattern of connections are there and there's a clear intermediary between that subtype of autism and that metabolite, give it a high score, so you get a 0.99. So now what we do all 4,000 drugs, all 18,000 diseases. So it's about 75 million scores that we generate, that our machine learning algorithms generate. And then that gives us a list in rank order from the things that are 0.99 all the way down to things that are 0.00 of every drug versus every disease. And so we come across matches that are incredible that we never could have imagined, that now the algorithm is saying, you should really look at this.
It's like the body is so complicated, these drugs are so versatile. It's like our minds can't even comprehend that. It's like, that's why you need to go to AI.
You would have to, as humans, think about 75 million possibilities. Like my lab's really good at looking at like dozens of possibilities for like one disease. Like my lab can spend like a year we get through a few dozen for one disease, right? But like we could never think about like 75 million possibilities and then compare them. And I'm not saying AI is perfect, but directionally it's really good. The things that are the 0.99s are way better than things that are the 0.5s.
How likely do you think it is that, like, if there's an ordinary person with ordinary disease that existing treatments don't work for, that there is something in there for them?
Yeah, I guess there's two probabilities here. I think that one is that what is the likelihood that there is a drug out of those 4,000 that could work for that disease, and then what's the likelihood that you or anyone else is going to find it, right? Because it's just like A, does it exist, and B, can you find it?
Yeah.
I think that A, does it exist? This is obviously a really hard thing to guesstimate on, but like I'm going to say somewhere in the realm for any given disease, somewhere in the realm of maybe 10 to 20% that there's something out there. And then in the realm of are you or is a team going to find it in time for you, it becomes much lower than 10 to 20% likelihood, right? Just because the steps that have to happen.
Right.
And so for us, we're going to be the organization that is going to identify and unlock as many of these drugs as possible. So that way we don't have to be throwing Hail Marys, so that like when you get diagnosed is, oh wow, you have pulmonary arterial hypertension, you should just take this medicine. Oh wow, you have glioblastoma, you should take this medicine. And so we've intentionally taken the approach of let's use AI and data to find the best uses for the best drugs so that we can move them forward so that way we aren't doing Hail Marys. But the reality is that like people are suffering all the time and we're contacted all the time and we want to help any way we can. And we're going to be making our algorithms publicly available in about 9 months' time. But until then, we want to continue to improve them. We feel this tremendous responsibility that once we share it, that it's out, right? And so we're going to continue to improve it over the next 9 to 12 months. But then we will share it.
And are you imagining patients would use that, or are you imagining doctors would use that?
So the intention will be for doctors and researchers to use it, so that way they can come up with new areas for research. They can think about it for their patients. But the reality, I think, is that patients will also use it.
I'm trying to imagine, like, so that is really interesting that you're making that public, and I think it's also like there's something. So the conversation went on for a while after this, but I was honestly surprised and a little taken aback that this algorithm that David had made, that he was going to take it public, and it took me a while to kind of process that and figure out like what I thought about that or what I even wanted to ask him about that. That part of the conversation, which actually felt a little bit trickier to me, is coming up right after the break. Stick around.
This week on the New Yorker Radio Hour, what the tech industry learned from Elon Musk's tenure in the White House.
Don't be weird. Elon Musk flamed out because he was wildly overexposed. But ultimately, if they've learned anything from what Elon Musk was able to accomplish, it's that this is open season.
Katie Drummond of Wired joins us next time on the New Yorker Radio Hour from WNYC Studios. Listen wherever you get your podcasts.
Okay, so I did that interview with David Fajgenbaum, and it's funny, he genuinely surprised me when he said he was taking this thing public. Like, I had not heard or seen that before, and it's since being reported that he's doing that. But when we did the interview, like, I didn't know he was going to say that. And so when he said it, I was like kind of shocked that he would do that. It like re-slotted the story in my brain from being like a slam dunk, like a no-brainer, best possible use case for AI, to something that was like, wait, what do I think about this? Should ordinary people be able to look up what drugs AI thinks will help them? Is that helpful? Is that reckless? So I really didn't know what to think. I called up a bunch of my doctor friends. Some thought it was like so exciting, especially for people with rare diseases, where there's not a lot of research money. They were like, yeah, this tool is going to be so useful for so many people. But then there were other doctor friends of mine who said, no. This is going to make my job harder and it's going to hurt people, which you will hear more about in a minute. Anyway, so I called David back and I had way more questions, and I was just like, okay, just tell me the specifics. What are you putting out there exactly, and why are you so sure this is a good idea?
Sure.
Like, I don't even know what to call it. Okay, your AI matchmaking tool, what do you call it? How do you use it?
Yeah, so we call it the Matrix. So it's an acronym. Everything has to have an acronym in my life. So it's ML aided therapeutic repurposing and extended uses. Matrix.
Okay, so ML aided, machine learning aided,
Therapeutic.
T for therapeutic.
Repurposing R.
Yeah. Okay.
I-N, and then it gets a little sloppy then. Extended. We're using the X in extended.
Okay.
For
Extended.
Matrix uses.
Oh,
Yeah.
okay. Then usage.
There's no uses doesn't get a letter. It's not Matrix U. It's just Matrix.
Okay, because you're a fan of the movie or something.
It actually is a matrix in that it's 4,000 drugs, it's 18,000 diseases. So it's actually we're building actually a matrix of drugs versus diseases, and the fan of the movie.
Okay, so how does it work? Like, say I'm just somebody, I'm a random patient with random disease, and I want to use it. What do I do?
Yeah, so we're still working on some of these things. We're actually literally talking about prototypes and processes, but I can tell you that there'll be the ability to type in the name of your disease or maybe the drug that you care about, probably more likely the disease that you care about, because most people care about diseases as opposed to drugs. But then actually it'll look at a rank order list for that disease. So say oh wow, I care about ALS. These are the 4,000 drugs ranked in order for ALS according to this AI platform. That I'm almost certain will be available in a format like that. But the bells and whistles we still have to work out.
Is it like a ChatGPT style thing? Like, I'm imagining you put your disease name into the thing, and then it'll spit back out at you a bunch of names of drugs, and it'll give you the percentage.
Yes.
But then you can also be like, hey, by the way, I'm also a smoker, and I have diabetes or whatever other conditions you have, and then it'll like how much information would you put in as a user?
I mean, what you're describing would be sort of like a holistic patient support treatment tool, and we're really not building that. I hope someone does. Someone should build that, but we're not building a tool that is going to be that sort of treatment co-pilot. Though I would love for someone else to do it.
Okay, so this is very much just insert name of disease, and what's going to come out is a list of names of drugs that may or may not work, and here's the odds that they will.
Yeah, and these are in the same list that we're getting on our medical team and our research and development team. We're giving you the same results and same scores that we're getting, because we feel this obligation or this responsibility that if we're going to put our eyes on them, the world should be able to put their eyes on them. Here are the tools that we use. Our medical team uses these same machine learning algorithms. You can use them too, but it's important to remind them that when our medical team uses those machine learning algorithms and they come up with something like lidocaine for breast cancer, we still then go on to do a bunch of laboratory work of lidocaine in breast cancer. And then we think about doing the right clinical trial of lidocaine in breast cancer. So it's not like we use the algorithm to immediately move forward into action. We use it to then plan out what to do next.
Okay, so why did you make the decision to make it public?
So our feeling is that we, as a nonprofit at Everycure, we're only going to be able to go through dozens. I mean, if we can get into the hundreds, I would be over the moon about it. But there are still thousands of diseases that could potentially benefit from our scores that we'll just never be able to get to, unless
it's because the list that Matrix is spitting out is just so big. Is that it? It's
so big and it's so powerful. The things when we look at the top, we are blown away by the number of promising drugs. We're like, wow, and actually, some of the cases, there's actually been clinical trials that have shown the drug works. But someone stopped after the small trial because there was no way to commercialize it. So one part is let's make it available to the world so that other people can pursue these things that we're not able to go after. And the other is sort of probably a little bit inspired by maybe we shouldn't be so paternalistic in medicine, and maybe we should allow this information to be out there. Of course, when I say that, I do cringe just a little bit because I don't want us to create problems by putting this out there. But it feels like the responsible thing is to share the scores, but to appropriately caveat them and disclaim them to say these are for research purposes. At Everycure, our nonprofit, we don't take a score and then put that drug into a person. We take a score, we evaluate it by MDs, PhDs, and MD PhDs. We spend months on it, and then we do laboratory studies, we do clinical trials, we work with experts to get into guidelines. That's our process, so we want other people to take a similar process.
Have you thought about what could go wrong by making this public?
Yeah, a couple things immediately come to mind. I mean, number one is patient harm. a patient taking a medicine that causes harm to them, that had not undergone the studies necessary to evaluate it in that disease. Now, the good news is that every drug we score is already FDA approved for something. So there's no drugs on there that like someone would be like, oh my gosh, this never got a regulatory approval. They all have been approved
You're not
by the
recommending
FDA.
cyanide to people.
Yes, exactly. Yeah, cyanide is not on our list.
Right.
Actually, I will tell you, there is a drug repurposing platform that I will not name on this podcast where literally one of the top 5 predicted drugs for Castleman disease, or predicted treatment for Castleman disease, is car fume exhaust as a treatment.
No.
This was the top predictions that, like, I guess
What?
inhaling car fumes, like, it
And
fumes.
this is just like an AI hallucination kind of thing?
It was like AI. It was like AI made the connection to be like, you know what? You just and I was like, oh my gosh, that's the problem. I just haven't been inhaling enough car fumes. Like that's why my Castleman's is out of control.
Right.
I just
yeah.
need to do inhale car
Every
fumes.
morning after breakfast.
So I say that not just to say that, oh my gosh, this one platform had this bad prediction, but it's to say that AI is going to make silly predictions that make no sense.
Not silly, like harmful.
Harmful, yes.
Right.
That's why humans have to be a part of this.
Right.
And humans who can critically evaluate this and say, like, this is not good. So I think the most important thing is going to be, I think, how we communicate around these scores when they are made publicly available. That these scores are intended for our research team to find things for us to research more. These were not ever intended to be, scores to say this thing that's number 1 is what I should get because that's going to save me. And so I think it's going to be context is going to be really important.
But like, what's the thing you say? Like, how do you expectation set in a really clear way to make it super distinct? Like, this is a machine that generates research ideas versus something that tells you what drug to take now.
I see what you're saying. Your point is that you can say it all you want, but for that just may not stick, right?
It may not stick, and also people are desperate. Like, a lot of these people, I mean, you know better than I do.
Yes, they will do anything. It's a great point. I think that the way to make it stick, I think it's trying to explain that we don't use these predictions to decide how to treat someone. This is not, and maybe even to use the terminology, this is not a solution engine. This is an idea generator. And we at Evercure do a lot of further work. And so we hope you, if you're going to use these scores, will also do further work. And so if you're a patient, that might mean working with a research lab to do the work to figure this out. What we recommend is talking to the disease organization that you're a part of, whether it's the ALS Association or you name it. It's talking to a lab to see if there's further work you can support. But none of those options are go take this medicine.
I'm trying to imagine, like, so that is, like, there's something beautiful and hopeful and democratic about that. I can also see, though, there's a big danger here. Like, okay, so I talked to a friend of mine about what you're doing, and she was like, I've already seen this play out. Like, she's like, I know exactly what's going to happen. I saw this play out with ivermectin during COVID. So all my patients were coming in, asking me for ivermectin, even though, like, I knew that wasn't going to help. She was like, last week, someone asked me for ivermectin for cancer. It's an antiparasitic drug. It's not going to help you for your cancer. So I said, no, I'm not going to sit here and prescribe you a thing that there's no evidence for. But what then this is doing is it's like driving a wedge between the patient and the doctor. Because now, once the doctor says no to the patient, then the patient now doesn't trust the doctor. Now the patient is either going to probably, go doctor shopping until they find a doctor who will prescribe to them, or they'll wind up at the black market or do medical tourism or some other non-ideal situation. But anyway, her point was that the doctor-patient relationship is already in a bad place. Like, it's already in a really bad place, and now if patients come in with these drug recommendations, like, who knows? Maybe they'll be great, but also maybe they won't. And then she has to be the doorstop. Like she has to be the one who crushes the hopes and dreams and has to hold to them. And that's like,
I agree, and I totally empathize and can really, like, see the concern. concerns. I think that where I go when I think about COVID is not so much ivermectin, but I go to dexamethasone. So dexamethasone saved millions of lives during the pandemic. It was the only drug relative that was recommended against when the pandemic started. It was whatever you do, don't give people a corticosteroid. Corticosteroids weaken your immune system. Don't take dexamethasone. Literally, there was no recommendation for what to take. There was only recommendation for what not to take. Well, some amazing pioneering doctor in the UK still decided to do the trial of dexamethasone, and it worked to reduce mortality by 35%. But the prevailing medical system believed that it would actually be harmful. So we didn't know what to do. We just don't do dexamethasone. Turns out dexamethasone actually reduces the risk of death by 35%. So I'm so glad that someone asked the question, are we sure dexamethasone shouldn't be used? So I love that. I'm glad that Dex saved like millions of lives. I'm glad that that there was sort of one doctor who was willing to go against everyone else. And so I think that the whole point of this is to find dexamethasone, not ivermectin. If there's a drug that someone thinks might work for a disease and it's snake oil and it's not working, we want to study it. We want to prove that it doesn't work. If there's a drug that looks kind of promising but no one's studying it, we want to study it and prove that it does work. We just want to prove that they work or they don't work.
So do you feel like what you're doing, do you feel like, oh, this existing medical system needs to be respected, it needs to be shored up, and it's like you're trying to like fix the part of it that's wrong? Or do you feel like it's like, no, the existing systems are failing us in these key ways, can't be bogged in by them, like I'm building a whole new thing.
Yeah, I think where my mind is that I think I'm still so appreciative for what doctors do for patients and that doctors bring just this laser focus on helping the person in front of them. So grateful for that. I'm so grateful for all the things that our biomedical system has figured out are true. Like this drug works for this disease. Like, I'm so grateful for that. So I don't want to break down any of that. Like I want everything about our doctors caring about patients and the relationship, and I want everything about all the known knowns, like when we know this drug works for this disease. I think what I really, really want to bring forward is uncovering the unknown. So that way those doctors can use, that unknown can become a known, so it can be easy for them to use it. I don't want to create some crazy new system where patients are picking drugs off AI. Like, I want to use AI so we can find out what we can elevate to the level that a doctor feels comfortable. Like, wow, that steroid actually could be useful for this thing. Huh, never would have thought about it. But you know what? They did a clinical trial and it worked. So, like, I'm going to do that. So, in my opinion, it's not about breaking down the system. It's about enabling the system to do exactly what it's trying to do, but that we're caught up in these assumptions that I think we have around what we know and what we don't know. And I think we're certain, we're very good at what we know. Like I believe everything we know in the system is rock solid. I think we're just not as good at understanding what we know to be not the case versus what we just don't know at all. Like the amount of and actually there's a term for it that the computer scientists use, and that's the ignorome, which is basically the things we don't know about medicine. Like the ignorome, I think, is a lot bigger than most of us in medicine want to appreciate. And I think if we can be a part of uncovering the ignorome and making it less ignoramus, or whatever it is, then I think that that's where we can serve medicine, doctors, patients, and not to try to break it down. And it's really about lifting things up.
Yeah, I mean, look, you've already been doing miraculous work. At the same time, I can't help thinking about this other Radiolab story that we did. I don't know, it was like a year or two ago, about this ICU doctor named Blair Bacom, who was kind of like you, was like the annoying patient relative, and the story is kind of about him watching his dad basically contract cancer and die. And his takeaway from that experience was like, we don't need more hope. We don't need more like Hail Marys at the end. We need more dignity. Like we glamorize doing everything we can, because we want to like keep the people we love alive. But actually, the reality is like those last ditch efforts like tend to make things worse for the patient. hospital, and now it's funny because I'm talking to you, and I feel like you have the exact opposite, 180 degrees different takeaway. Fight, 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 never say die. Like, try every drug in every pharmacy. So I just don't even know. Like, how do you square those two things?
So, I actually think that during this discussion, I think you've actually sort of opened my eyes a little bit. Just because you sort of like highlighted to me, I just told you the 3 most special months of my life were the last 3 months of my mom's life when we weren't fighting for a treatment. Yet I just try to extend other people's lives with the drugs we already have in my own, and so I think everything's context dependent. And I mean, if I think that what he said is conceptually correct, but I think that when you feel it, when you experience it, especially when you experience like the positive side, when you do make it, it creates a new sort of value that you put on if you do get extra time. But of course, this at the end of the day, this is like philosophical around like individual versus collective societal. Like, you know, there are people that will say like, I want to die at 70 years old because I don't want society to have to take on my burden. Like, even if I'm not sick, like I just should die at 70 years old so society doesn't have to pay for my costs. And then there's other people who are like, we're only on this earth once, like I'm gonna like squeeze out all the time I can get. You know, I'm gonna live as long as I can get. I don't think that I'm sort of on either camp. I think you can, be reasonable and decide. I mean, I should also share about a patient recently that that I had helped to discover a repurposed drug for, and it got him out of the ICU. And I remember sitting with my team and jumping up and down. And like when we got the news that he was responding to this medicine, it was like literally.
What was the sickness he had?
He has calcium, the same exact subtype that I have.
Wow.
It was just, I was so excited. I remember I cried tears of joy. I was so happy that we found this drug for Paul. And the next couple of weeks went by, and he kept getting better. And he got out of the hospital, and I got in touch with him, and he explained to me, David, this drug got me out of the hospital. It turned everything around to save my life, but I feel horrible on it. It makes me nauseous. I'm vomiting all the time. Like, it's just controlling my disease, but I don't like the way that I'm living. And he was a 70-year-old gentleman, and he decided to go off that medicine for the exact reason you mentioned. Was it was I want to spend the time that I've got with my kids and with my wife.
Yeah.
And I was like, Paul, but we already found something for you, and it got you out. Like, we've shown that we can do it. Like let's try another one. And he said, no, David, I don't want to. And then the two of us just cried, tears of sadness. Cried tears of joy before that, cried tears of sadness. But it was okay. Like, this is his decision. Like, he knew that if he put me on the case, he knew that I was going to be all in, and he knew that I'd been able to do it once before. Like, but he told me he didn't want to. I was very sad, but I felt that it was absolutely the right thing, and I 100% respected it. I understood that, like, for him at this moment in his life, that was the right decision. And he passed away a few days later.
So you're saying it just basically, it needs to be personal, it needs to be case by case.
Yeah. Maybe that's the big takeaway, is that it seems like everyone wants to tell us what everyone else's decision should be. So, like, it's best for society for you to do this, or it's selfish of you for you to do this. But I think that maybe that's the real fundamental thing this comes down to. It's got to be that patient's decision.
This episode was reported by me, Latif Nasser, produced by Maria Paz Gutierrez, edited by Pat Walters, and fact-checked by Natalie Middleton. Special thanks to all of the folks at TED, including Chloe Shasha Brooks and Helena Bowen, who introduced me to David and his work. I was right there in the wings when he did his talk on the TED stage. That talk should be on their website, the TED website, very soon. And in the meantime, for more on David's story, you can check out his book, Chasing My Cure, or for more on the work that he's doing, you can go to their website, everycure.org. Special thanks to Peyton and the rest of the staff at Every Cure. If you have not had enough Radiolab, we referenced 2 prior episodes today, and I think they're both totally worth a listen. The first was the one I mentioned about that ICU Dr. Blair Bigham, who basically writes a book about how we should make our peace with death and we should die with dignity. And then while his book is on the bestseller list, his dad gets pancreatic cancer, and all of a sudden, everything he wants to do completely contradicts everything he wrote in his book. That one is called Death Interrupted. Second Radiolab episode that we mentioned was kind of the backstory of the drug that saved David's life, rapamycin. It is an entirely improbable backstory. It is shockingly dramatic. It's about one immigrant scientist who basically single-handedly saves this potential drug from the trash can by smuggling it across a border. That episode is called The Dirty Drug and the Ice Cream Tub. That is all for us today. Thank you so much for listening. Until next time, I wish you good health.
Hi, I'm Connor, and I'm from Minneapolis, Minnesota, and here are the staff credits. Radiolab was created by Jad Abumrad and is edited by Soren Wheeler. Lulu Miller and Latif Nasser are our co-hosts. Dylan Keith is our director of sound design. Our staff includes Simon Adler, Jeremy Bloom, Becca Bressler, W. Harry Fortuna, David Gable, Maria Paz Gutierrez, Sindhu Nyandan Sambandan, Matt Kilty, Annie McEwen, Alex Neeson, Sarah Kari, Sarah Sandback, Anissa Vitsa, Ariane Wax, Pat Walters, Molly Webster, Jessica Young, with help from Rebecca Rand. Our fact checkers are Diane Kelly, Emily Krieger, Anna Pujol Mazzini, and Natalie Middleton.
Hi, this is Jenny from Brooks, Maine. Leadership support for Radiolab science programming is provided by the Simons Foundation and the John Templeton Foundation. Foundational support for Radiolab was provided by the Alfred P. Sloan Foundation.
I'm Ira Plato, host of Science Friday. For over 30 years, our team has been reporting high-quality news about science, technology, and medicine. News you won't get anywhere else. And now that political news is 24/7, our audience is turning to us to know about the really important stuff in their lives. Cancer, climate change, genetic engineering, childhood diseases. Our sponsors know the value of science and health news. For more sponsorship information, visit sponsorship.wnyc.org.
This is the TED Radio Hour. Each week, groundbreaking TED Talks.
Our job now is to dream big.
Delivered at TED conferences
to bring about the future we want to see.
Around the world.
To understand who we are.
From those talks, we bring you speakers and ideas that will surprise you.
You just don't know what you're going to find.
Challenge you.
We truly have to ask ourselves, like, why is it noteworthy?
And even change you.
I literally feel like I'm a different person.
Yes.
Do you feel that way?
Ideas worth spreading. From TED and NPR. I'm Manoush Zomorodi. Writer Kelly Corrigan's daughters are grown now. But back when they were tweens, she noticed something. If they came home from school really mad or upset, and she tried to help them, they would just turn off.
Their emotion would change and they would go from something raw to something kind of tired and dismissive, and then they would wander away. And I would think, what just happened? Like, they told me they're upset about X. We brainstormed solutions to X. And they seemed so unsatisfied with my parental interference.
This really bothered Kelly, to Until one day when she was on a road trip with her old college roommate, Tracy.
We were going back to some reunion, and she was in graduate school to become a therapist.
As they drove, Kelly's daughter, Georgia, called.
She was very upset about something. And Tracy was sitting next to me, and I put the phone on speaker because I really wanted Tracy to hear the drama in Georgia's voice, and also maybe to like Cyrano de Bergerac me, like to just tell me what to say.
Georgia was crying. She hated 6th grade. All the girls in class were turning on her for no reason.
So Georgia said her things, and then Tracy said, "Tell me more. Say, tell me more." And then I'd say, "Oh, tell me more." And then Georgia would tell me more. And then Tracy would say, "That sounds really hard." And then I'd say, "Oh, that sounds so hard." She'd say, "It is." And Georgia would go on, go on, go on. And then Tracy would say, "What do you want to do about it?" And I'd say, "So what do you want to do about it?" And it was like acting. I was completely trusting Tracy's advice, and it was uncanny to me how effective it was. And what it taught me is that I think it's kind of humiliating when you bring a problem to someone and they solve it like lickety split. Because basically, the underlying message of that is, what are you so upset about? Like, it's not that hard to figure this out. And that's a terrible feeling. Versus the joy of like untying the knots yourself. So I always picture someone picking through like a giant jewelry box full of necklaces and earrings and bracelets and brooches, and everything's all tangled up. And there is a tremendous satisfaction in separating all those items once and for all. And so either you're going to let the person have that satisfaction or you're going to steal it. And once I heard myself phrase it that way, that it's stealing satisfaction, that helped me stay on the right side of things. Like, don't you dare solve this for them. Don't grab that. That's greedy. Like, let her solve it. That's really the call here. And that's brave because you are putting aside your own methods and your own sort of delivery mechanisms that are most comfortable for you. You have to decide that their needs are paramount. That you are not trying to serve both needs at the same time, and you're definitely not trying to serve your own needs over theirs.
We want to fix problems, win the argument, make friends with the tap of a screen. But what does it mean to truly be close to someone? And how can we have the courage to put ourselves and our fears aside? Today on the show, ideas about being brave in relationships. From dealing with family baggage to a scientifically proven way to stay married, and from one of the most famous relationship therapists of all, wisdom on how to make friends in what can feel like a lonely world. Kelly Corrigan believes that to be the most helpful to the most important people in your life, you just need to say a few phrases. Tell me more. Go on. What else?
Those are the 7 words. And you can get pretty far in life just with those 7 words.
She spent years talking about families, her own and many others, on her PBS show, her podcast, and in her 4 best-selling books. And Kelly thinks that when it comes to a crisis, that is when we most need that quiet, soft kind of bravery.
Inside every crisis you think you might be ready for are 100 dirty surprises that are not in the playbook.
Here she is on the TED stage.
I had stage 3 cancer in my 30s, and I can tell you that following the chemo schedule didn't take nearly as much courage as admitting to my husband that sex felt less sexy after my boobs, which were once a real strong suit for me, were made weird and uneven by a surgeon's knife. This bravery I'm talking about might even be better understood if you look at the smaller moments of injury in family life, when there's not really an answer, or it might be your fault, or it might remind you of something you'd rather forget, or because people are so suggestible in the wrong tone or expression or phrasing might somehow make things worse. Say your kid was dropped from a group text. They were in it, they mattered, they belonged, and then poof. Or your husband blew the big deal at work, or your mom won't wear the diapers that would really help her get through Mahjong on Wednesdays. And how should we calibrate the exquisite bravery to respond productively when someone in our family looks at us and says, "Do I know you?" I weigh myself before and after every meal. I hear voices. I steal. I'm using again. I bought a gun. I stopped taking the medication. I can't stop making online bets. Sometimes I wonder if more life is really worth all this effort. Bravery is the great guts to move closer to the wound, as composed as a war nurse, holding eye contact and saying these 7 words. Tell me more. What else? Go on. That's how the brave shine. That's all they do. They say, tell me more. What else? Go on. Even if they're scared of what might happen next, even if they have no training or experience to prepare them for this moment, even if it's late and they have an early flight.
The theme through your books, through your talk, is about how important it is to be present, to listen in our family relationships, however you want to define family. But it is so hard to do when you are tired, when you're trying to get dinner on the table, when you feel like, oh my God, my kid is like complaining again. Like, do you know how much it costs to send you to that camp? What advice do you have for being present in a, I guess, a doable way?
I do think that it speaks to the inconvenience of vulnerability. Like anyone who has children knows that they often come in right as you're turning off your light to go to sleep. And they want to tell you something, or you're pulling up to the airport, or there's some imminent drop-off coming. And I think that bravery requires a setting aside of self and a setting aside of ego, such that your whole being, everything you've got cognitively and emotionally, is available to the other person to lean on. If a person is in front of you telling you, I want to say all these horrible things, I want to tell you how awful I feel, like, can you even hear it? Can you absorb that? And are you signaling that you can? Because another thing I've thought about a lot over the years is that the job is, if you really love someone, the job is to make sure they know it, which requires a little customization. You know, not every kid wants to be hugged repeatedly or sent cards in the mail. Like, the whole love languages thing is so valuable here, which is, what would it look like if I were to custom design a feeling for you? What would the shape of it be? What would the sound of it be? Don't put too much pressure on yourself to say the right thing. I'm so thrilled by the idea of that kind of emotional hospitality, where you're like, I tell me something. I'm here, I'm listening. So few people love to listen. Most people, it seems, love to talk. Here's 2 things the brave don't do. They don't take over and become the hero. In families, bravery is mostly just sitting there. Personally, I thought love meant action. I had no idea it could be so still. When things get hairy for one of my people, everything in me wants to grab a clipboard, make a to-do list, and start calendaring appointments. And all that can accidentally put us center stage. No longer the coach or the minister, but rather one of the afflicted. But these gritty endurance types I've been admiring have no self and no needs and no agenda, or at least they know how to override all that for the main character, who is not us. The second thing the brave don't do, leave or hide in beside work or hobbies or some other socially acceptable busyness. In my worst moments, when sitting on my hands is just unbearable, I have dreamed of going to get an MFA in Paris. Because if I can't help, why do I have to watch? It would be nice to leave and start again. Hardly anyone who's been in a long marriage hasn't at least wondered how it is that the object of their desire has become so burpy and farty. Sometimes I see myself naked, stretch marks from pregnancies, scars from cancer surgeries, other things that I don't feel you need to be visualizing right about now. And I think it's a miracle that man stays with me. But you know, he's not untouched by time either. And that's just the physical. I mean, who here hasn't wanted to be with someone who hasn't seen us eating on the toilet or bitching at the Comcast guy? Leaving behind our own humiliating history, maybe with the nice person we met at art school in Paris. It's an option. People take it. The brave hang around. They are available and ready to bear witness.
In a moment, Kelly Corrigan explains how she applied this same philosophy to the final days of her father's life. On the show today, bravery in relationships. I'm Manusha Zamarodi, and you're listening to the TED Radio Hour from NPR. Stay with us.
This message comes from NPR sponsor Design Matters, a podcast from TED. Host Debbie Millman interviews incredibly creative people to find out how they design their lives. One of the world's very first podcasts. Listen to Design Matters in honor of its 20th anniversary this year. Support for this podcast comes from PBS with Clearing the Air, The War on Smog. In 1943, dark, smoky clouds suddenly descended over LA, causing residents to complain of burning eyes, nausea, and difficulty breathing, and the cause remained a mystery. American Experience chronicles the struggle for clean air and the science and activism that would lead to the creation of the EPA and the Clean Air Act. Clearing the Air, The War on Smog airs Tuesday, August 26th at 9, 8 Central on PBS.
It's the TED Radio Hour from NPR. I'm Manusha Zamarodi. On the show today, what it takes to be brave in relationships. We were just hearing from writer Kelly Corrigan on why sometimes the bravest thing you can do for the people you love is nothing at all. You ended up applying this same philosophy in one of the last conversations you had with your father. Can you tell us that story too?
Yeah. So my dad was just days away from dying. And he was completely willing to have me sit in bed with him, to hold hands with him for hours. Like, he was telling me in the way that he was responding to my outreach that, like, this is it, and we should gobble up this time that we have together. And he felt more or less at peace. He was 84 years old. He'd had a spectacular time while he was here. But there was this day where he felt kind of agitated, and you could only see it if you were very quiet and very tuned in, which I consider to be an act of bravery. To not rush around and be moving things around on his nightstand and telling him to go to sleep and bossing people around, but rather just sliding in next to them and mirroring their mood. And so I was looking at his forehead, it's all wrinkled up and tight. And he said, Lenny, I should have gone to see your Uncle Tommy more. So Uncle Tommy is my mother's brother. He died at 46 of a brain tumor. My dad loved this guy. And it had been a long time. It had been maybe 40 years since Tommy died. But right then and there, he had this discomfort with his failure to give more to Uncle Tommy. And And instead of saying, "Oh, come on, you're an amazing brother-in-law," to him, I said, "Tell me more." And he said, I should have named a kid after my lacrosse coach. And it was like, what? Why? Tell me more. And he said, he was so important to me. I went to college on a scholarship, and I almost blew it. I was partying too much. I didn't take it seriously. I was late to practice. And the guy took me by the shoulders and said, "You got one more week on this team or I'm sending you home." And he shaped me right up. And it was like, what else? Like, is there more? And of course there was. And so we spent the day reviewing these little regrets that he had that were so, to my mind, so innocent. I mean, it was almost like the mood of him was that he was going to tell me he had cheated on my mother, or that he had an illegitimate child, or that he had embezzled. But the fact of it was very small to me, to my eye. But of course that goes to this larger point, which is it doesn't really matter what it looks like to my eye. Like whatever's weighing on you is weighing on you. And it was like, I'm gonna hear you. I'm gonna absorb this thing with you. I'm gonna mirror your seriousness about it. And maybe that can let you rest. And it did. And he leaned back on his pillow and said, "I'm good, Levy. That's good for today."
What a gift you could give him by doing that.
Well, yes, I suppose, but also such a gift to me to get to give it. Like, there's so hard. It seems almost impossible, really, to love someone effectively and productively and sufficiently in that moment. And he was offering me a way. And I took it. And I always have it. Final act, then, of the truly brave is leaning back and letting them go. The reward for all this bravery is a full human experience, complete with all the emotions at maximum dosage, where we have been put to great use and found an other-centric love that is complete in its expression and its transmission. The reward is to end up soft and humble, empty and in awe, knowing that of all the magnificence we have beheld from cradle to grave, the most eye-popping was interpersonal. So here's to anyone who notices and reads between the lines, who asks the right questions but not too many, who takes notes at the doctor's office and wipes butts young and old, who listens, folds, and stays. We who, untrained and always a little off guard, still dare to do love, to be love. That's brave. Thank you.
That was Kelly Corrigan. Her latest book is called Tell Me More. You can see her full talk at TED.com. So that's being brave, showing up for your family. But what about your spouse or partner? How do we show courage one-on-one, especially when we're in disagreement?
Yeah, fighting is very normal, it's very natural, just by virtue of the fact that each of us has a different brain from the other person. We've been raised differently.
We actually need conflict because we're not attracted to people who are just like us. And we have to keep understanding our partner as we change and grow.
John and Julie Gottman have been married for over 35 years, and they are very well known for being pioneers in the field of couples psychology, specifically researching why some couples stay together and others don't. It all goes back to 1986 when John and a colleague created a laboratory to study couples at the University of Washington. Julie joined them soon after. They called it the Love Lab.
We wanted to see whether we could predict the future of relationships.
Here's what they would do.
Couples would come into the lab, sit down, typically facing one another, and we would ask them to think about a problem that they hadn't solved yet, that they wanted to talk about.
The Gottmans interviewed couples over the course of weeks, months, even years. But there was something unique about their method. The conversations were recorded, and each person was hooked up to monitors to measure heart rate, blood velocity,
Skin conducted sweating from the palms of the hands, respiration, and a variety of other signals. And they were synchronized to the video time code.
Analyzing what their facial expressions, their body movements, their words, and their tone of voice all conveyed.
After collecting reams of data, the Gottmans started to see patterns. For example, if someone got upset and stopped responding in the conversation,
their heart rates were typically over 100 beats a minute. They might be breathing very shallowly. They are basically having great difficulty hearing the other person, interpreting what that other person is saying, and creatively problem solving.
over the years, they would follow up with couples and track whether they stayed together.
And we found, surprisingly, that we could predict with over 90% accuracy the future of a relationship.
This work continues today, but with a boost from artificial intelligence.
Now, most of that is automated, which is somewhat miraculous. We are getting hundredth of a second by hundredth of a second what is happening to a couple.
They've now studied thousands of pairs in conversation and codified their findings into various laws or rules for relationships. The most famous one is called the Four Horsemen of the Apocalypse. Basically, 4 reactions that, if they show up during a fight, may mean a couple's demise. Here are Julie and John Gottman on the TED stage.
The first one was criticism, blaming a problem on a personality flaw of your partner. For example, oh my God, this place is such a mess. Why are you such a slob?
The second horseman is contempt. Contempt is like criticism, but it has a dash of superiority. You include scorn, disgust, sarcasm, and nasty insults.
The third horseman is defensiveness. That's the most common one. And that's when we act like an innocent victim. I did too pay the bills.
The fourth horseman is stonewalling, where we shut down completely and we don't even give the speaker any signs that we're listening.
And what we discovered from the physiological research is that people who stonewalled tended to be what we call flooded, which actually means in fight or flight.
So, when you're flooded, you really feel like you're in danger of dying. You feel so threatened by your partner that you start to really secrete these stress hormones, cortisol and adrenaline. And it creates a kind of tunnel vision where they can't really listen, they can't really process information very well. And they wind up repeating themselves, thinking if they repeat themselves louder and louder, they'll be more persuasive.
Soon as you recognize there's flooding in the room, you say, I think we need to take a break. And you say when you will come back to continue the conversation so that the other person doesn't feel rejected. On the break, you distract yourself by reading, by listening to music, maybe watching TV, so your body has a chance to calm down. And then you come back at the designated time you agreed to, and typically people look like they've had a brain transplant when they sit down and talk again.
Okay, your latest book is called Fight Right: How Successful Couples Turn Conflict into Connection. And in it, you share examples from couples that you have studied. And I want to ask you about one argument in particular. This is a young couple discussing an upcoming visit from the in-laws. We have actually created a reenactment of their conversation, and we can play this case study now.
Oh, by the way, I told my parents they could stay in our room this weekend when they visit. We'll sleep on the couch.
You already told them?
Well, yeah, they're my parents.
You know I don't sleep well on the couch.
come on. It's just for the weekend. What's the big deal?
I want to be at my best with your parents, and I don't want to be grumpy because I didn't get.
Like you're ever at your best with my parents anyway.
Wow. Okay.
Why are you making that face? You know it's
Hey,
true.
I'm trying to make an effort with your parents. And
Oh yeah? Why has it taken 3 years for you to do
3
that?
years.
Why is
You don't
this the
think that I
weekend?
made an effort for 3 years?
Okay, so in-laws. It's a. I don't need to be a scientist to know that it's a touchy subject for many couples. Tell me, what did you each hear in that conversation?
Well, I heard a lot of criticism and a lot of contempt from the woman. First of all, he was caught off guard by her announcement. He sort of expressed that, but really didn't talk about his feelings. She failed to listen to his feelings about it. What's the big deal? She's minimizing his feelings, invalidating his feelings. He's really hurt by that. He goes defensive, and there's no listening going on whatsoever.
Yeah, he was ready to withdraw. We also know that his heart rate goes up to 95 beats a minute very quickly.
Right, this was a real couple. We're playing a reenactment, but you
Right.
actually measured them in your lab.
That's right. Just by using the video, we could measure the heart rate of both people. And turns out that trust really falls dramatically in this interaction. Trust means each person is really not just interested in their own benefits, but also really working to ensure that their partner's benefits are maximized. Is your partner there for you? Do they have your back? And we can compute that moment by moment. So they very quickly become strangers and enemies.
So how can they fix this?
So, what she could have said instead is what we call a softened startup. Let's say the fellow's name is Dan. So, Dan, I'm feeling a little anxious about my parents coming for this weekend. I really want them to be comfortable. So, how would you feel about our giving our bedroom to them while we sleep on the couch in the living room just for the weekend?
Okay.
That would be an opening question that gives Dan some freedom of choice.
Yeah, but he could really improve the interaction as well. If she says something like, "You really haven't tried for 3 years," he can say, "Gee, that's a really strong reaction to how I've treated your parents. I want to hear more about that. And give me a chance to really understand what your feelings are." So both people can play a role in getting to mutual understanding. And mutual understanding is really the goal of conflict.
I've been married for nearly 20 years now, and the thing I hear from people is almost in a resigned way, like, oh, we had a fight, it's the same fight we always have. You call these perpetual fights.
Right.
Are we all doomed in a relationship to have the fight that we've been having since we first got together over and over and over again?
Yes. However, this leads to a different intervention. It's called the Dream Within Conflict exercise. We have a series of 6 questions that really draw out the subterranean levels of how somebody feels about a particular point of view.
People are poised to fight one another because underneath their position, there are a lot of very important beliefs and hidden dreams.
69% of all relationship conflict problems are perpetual, which means that they never go away. And so we learn that conflict really mostly needs to be managed rather than solved.
Fighting to understand means taking a conversation about an issue and going much deeper to understand what's beneath your partner's position on the issue. That builds the connection. There was a woman who we will call Jenny, who was adamantly opposed to getting a dog. But her partner, Allison, was all for it. So they decided to try the dreams within conflict conversation. When Allison asked Ginny, so what is your ideal dream here regarding this issue?
You know, if we don't have a dog, we're not tied down, we're not burdened. We're free to travel the world together. That's what I really want. Now listen to what Allison said.
You know, I see getting a dog as a practice run for having kids and having a family. That's what I want.
Beneath the surface, it was about leading a life of adventure and travel versus staying home and raising a family.
You generate such a level of understanding that then they can compromise. Let's find a solution that honors your dreams and my dream.
But what if there is no solution? When we come back, Julie and John Gottman on Deal Breakers, the issues that no amount of understanding can fix, and that can spell the end for many couples. Today on the show, bravery in relationships. You're listening to the TED Radio Hour from NPR. I'm Manoush Zomorodi, and we'll be right back. It's the TED Radio Hour from NPR. I'm Manoush Zomorodi. On the show today, bravery in relationships. And we were just hearing from renowned couples psychologist John and Julie Gottman about how to fight right, to use conflict to strengthen a relationship. But let's say people follow the Gottman's methods and come to the conclusion that they want different things in life. What then?
It's true that sometimes one person's dream is the other person's nightmare, and they cannot reach a compromise. But at least they know why they're breaking up. A good example is one person really doesn't want to be a parent, and the other person really needs to be a parent. You know, that's a common reason why many people break up.
Another one that I've seen is geography. And this is interesting, you know, especially in our dating on the internet world. I treated a couple where they had met at a conference and then they had several rendezvous together after that. He lived in Uganda. She lived in Switzerland. And where were they going to live? They loved each other, but they couldn't make their future come true.
Another is polyamory versus monogamy. That's a more common one these days.
Mm-hmm. Are you seeing that working for people? It seems like the jury's out on that, at least here in the United States.
Yeah, there is no research on it, unfortunately. So, you know, we really don't know empirically what makes polyamory work. Another deal breaker, Manoush, that's really emerged quite recently in the last couple of decades is when a relationship really doesn't fulfill the growth needs, either career or emotional or spiritual growth needs of one person. And that's one reason sociologists have been saying that it leads to the end of a relationship.
I want to just make sure I ask you, you know, what is the payoff of fighting right? If we are brave enough to get in there and do the work, what do you see on the other side?
So the payoff is that we can have a lifelong love. And research has shown that when you can do that, you actually live an average of 15 to 17 years longer, you're healthier, and your kids turn out better. And their relationships, when they grow up, turn out better as well.
What I've seen in doing couple therapy for 30 years now is a different kind of love. It's much more profound, it's deeper, it much more recognizes the humanity of the other partner as well as your own humanity. And once you've seen one person in their fullness, including the cracks, you tend to be more forgiving, I think, of other people. And look at this world, Manoush. This world is split and fractured, and we desperately need a little bit more love and peace in the world. This is one way to start creating that.
That was Julie and John Gottman. They are co-founders of the Gottman Institute, and their latest book is called Fight Right: How Successful Couples Turn Conflict into Connection. You can see their full talk at TED.com. On the show today, bravery in relationships, which has to include friendship. But before we get into just friends, a warning that this episode includes some frank talk about sex.
Good evening, this is Dr. Ruth Westheimer, right here on 97 WYNY FM radio.
So maybe you remember the iconic sex therapist, Dr. Ruth.
Yes, you're on the air. Yeah?
She rose to fame in the 1980s because she was one of the first people to openly talk about sex on the radio and on television.
The way you can talk about reading, writing, arithmetic, you can also talk about sex.
She became a lively, warm, and non-judgmental voice for generations of Americans, including journalist Allison Gilbert.
I was one of those listeners.
Yes, you are on the air.
Dr. Wertheim, I know you're always concerned about birth control.
Yes, I am.
I was a teenager with raging hormones who found myself with a closed bedroom door, lights out, radio really so low that I was surprised I could actually hear what she had to say.
You know what I would do?
What?
Find yourself somebody else.
Oh, but I love Charlie, and he loves me too.
Because the callers, it was a call-in radio show, were asking her what I thought then were really naughty questions.
Give her as many orgasms as she would like. Try that, okay?
My mom was not prepared to talk with me about.
In a way, I do want to go to bed with him. I'm afraid that if I do, it's wrong for me to do this.
Right. I tell you, sometimes when I hear a 16-year-old ask me that question, I would like to say, what's the rush?
And so I was a fan before I was ever a collaborator. And so to say that I was in awe when I finally got to meet her at 95, she had been in my world, so to speak, since I was a kid.
As an adult, Allison was thrilled when she was assigned by the New York Times to write an article about Dr. Ruth's new role.
Dr. Ruth was on a mission to be appointed New York State's first ambassador to loneliness.
She had been reading and observing what the U.S. Surgeon General has called an epidemic of loneliness and isolation. And she was determined to be part of solving this health crisis by teaching people how to have the courage to form friendships.
She knew she can help. She had something to say. And the article that I was assigned was to report on this mission. And as soon as the article published, it's like both of our guards went down. And before I really realized what was happening, she was enveloping me. And what I have come to understand is like her web of love and friendship that seems, now that I look back, ever growing. And I just found myself fortunate to be in that space. And what I found was that warmth you heard through the radio.
I think that you should find yourself a new man, okay?
That magic that captivated TV watchers when she went on television.
You have changed sex for America.
Don't you tell me that it's less good.
No, it's better now. Everyone knows.
That to me was still present in her apartment, in her living room, despite her being, when I met her, mostly confined to a wheelchair. Do you feel that you are a good friend to others?
This is a recording of Allison and Dr. Ruth in the last few months of her life before she died at the age of 96 in 2024.
I began not only do I think that I'm a good friend, I'm a superb friend. I am like the best friend that anybody could have.
Allison became Dr. Ruth's collaborator on her final book, The Joy of Connections.
Since my late husband died, I wanted to write about loneliness. So now I am very happy to write this book.
Loneliness is a feeling that you want a deeper connection with people.
Until you're blue and black. 车一路追，顺利抓到人。
请我一下，你有拿着别人东西吗？没有啊。这是不是你？你去国盛充钱站偷我的包包嘛？
被害人拿出监视器画面，窃贼看到瞬间哑口无言，只能乖乖就范。这起窃案发生在花莲，日前女性被害人承接施工所工程，将车辆停在国盛抽水站，没有锁上车门，结果被50岁杨姓窃贼偷走3000元现金，还有住处、公司等5把钥匙，气得报警。第二监视器发现窃贼骑车经过一间机车行，推测之前可能在这里买车。一问机车行老板果然没有错，而且热心的老板灵机一动，帮忙打电话给窃贼，告知可以免费回厂更换零件，成功让窃贼上钩现身。
居然以涉嫌窃盗罪函送花莲地检署侦办。
以为自己幸运获得免费服务，开开心心来到机车行，殊不知早就被设局，遭到埋伏远警当场来个正着。TVBS 新闻高雄陈亚彤花莲采报道。
想看最完整的新闻内容，记得下载 TVBS 新闻网 APP。
我是真的会到后来，有时候是一开始有好感，然后后来无果嘛。后来
告白失败了。
对，告白或没告白就结束了之类的，就对方对象，或是后来就是反正就最后无果的话，感情无果的话，我是真的有可能转成完全的对这个人就是朋友。
那是因为你告白过，你攻击过。
没有，有时候没有告白过。
那他有间接打脸你过吗？你感觉到这件事？
可是我觉得这真的跟打不打脸没有关系。你打脸之后，其实根本就不会，没有，你打脸了，你结婚了，
你差点让我没有吐槽到。
就算这样子，不会改变你心动本质啊。对，但其实有可能到后来就慢慢的就没有那个质地在，就真的是跟朋友一样。
那菜口味菜也变了，对吧？
你要讲的好是菜本身变质了，
我是说你也会变化。
人成长了，然后去发掘某一些自己的面向的时候，也会有差别啦。对，就会觉得这部分可能是某部分那个时候因为这个心动或什么的，但那个东西其实，在经过年纪的增长之后，可能就已经不是会这样思考了。
他也是个 M， 我也是个 M。
对啊，那谁来拍我屁股啊？
你昨天晚上自己拍自己屁股。
那我们讲，因为有人担心说，平常这样相处吃饭，但不会啊。如果再深入一点的话，可能就会开始有一点怎样了吧？比如说一起吃饭，all safe， 一起撑一把伞。
你刚刚就帮我撑伞。
对啊，你刚刚帮他撑伞。
我他妈超辛苦，你知道吗？好彩那把伞很长。
我们每次帮他撑伞，我们的手都要这样。
我是握着底部那个弯钩这样哦。
你刚刚真的是纯撑伞哦，纯撑伞。
对。
放手机在说话好棒哦。
拿这个搞笑，就会有人拿这文章。你们爱喜欢煽风点火，鼓风机哦你。
然后呢？
然后就是越来越不同的这种亲密程度的话，有人会觉得这样子可能会点燃一些什么？你们觉得可以到什么？比如说一起吃饭没问题吧？单独吃饭。
可是
这样情况就不行了。
不是，可是真的是你到底你有没有诚实的去看，说这个对象在最一开始有没有我刚刚说的那个，就你对他是有多那么一点异性的好感？如果是有的，然后还没有经过不管打脸或告白或什么或失败，然后就开始说吃饭或什么，那我会觉得那就不是纯友。你不可能从一个你对他有一点点好感的人开始，然后跟他吃饭，你会说，因为我还在认识你，所以我自己不吃这条，我自己会觉得，其实我就是对你有好感，只是是多是少，但是只要有好感了以后，好像就吃饭就不只是吃饭，但不是说吃饭我要干嘛，只是说吃饭的过程。
你们两个就是一兰拉面嘞，
一兰
中间有个帘子，隔起来，你要聊天还要这样，懂？
没有，我会跟他做一格，同一格。
好挤。
你们是坐前后排是不是？
好傲哦。
我脸真半天，你知道这个。
真的客人好傲哦。
对啊。
那如果说假设你真的跟他认为你本来就跟他是朋友哦，女性朋友纯友谊哦，你没有那个动机什么东西咯，讲个极端的，一起住同一间温 温泉旅馆，同一张双人床，
不行，同一张双人床不行。
太明显了啦，
因为终究是异性啊。
对啊，尊重需要尊重。
我不说，不，我在讲尊重。
重点是这是跟2个人有关的，你怎么知道他对你是不是？
我跟他干。
哪有你啦？哪一种啦？我没有遇过这种，我没有遇过这种，好不好？
我干没差，
不要干好不好？
没有，他可能就这样子啊，干没差。
这种反而危险哦，有时候这种反而有点危险哦。
我以前
因为家里干嘛？
我以前有过吴修和，我跟他去那个花莲玩，然后那时候倒很穷，然后水子的，因为我们要
你为什么一直拖吴修和下水啊？你为什么？你为什么不想知道他爱过你啊？奇怪了。
他就是真的爱你，可不可以？结论了啊。
我们真的很纯，我们还住那种什么国军那种比较便宜的旅馆，然后一间，然后2张单人床。
2张单人床还好啊，
没有，我说
他说1张双人床
大床，
很尴尬吧？
我讲个最极端的状况，
还要极端哦。你说一起洗澡吗？还是什么？
同张床就好，一起洗澡那就是不可能，没有到不得已。
肥皂卷一下，兄弟，不是要说这种吗？
不是1张床，原因是因为最经典的那个案例就是订错饭店了，只订到一间1大床的，
干他故意。
谁订的？一定故意的。谁？
没有 Booking.com 就出错的。我就假设一个极端的状况，
你说。
对，你觉得那样子有可能变质吗？
这不是 A 片情节吧？
它是 A 片情节。
我知道。真演的。
对不起，这是一个超经典的 A 片情节。好，我就假设 A 片情节拿来用，因为 A 片情节就是说到这个程度的时候，它可能会变质，所以要假设这个状况。那你们觉得在这极端状况，就是本来对这人没感觉，你也觉得这个人对你就是没感觉，那你觉得一起睡在同一张床上会不会变质？
会吧？
你会吗？本来没有，就觉得2个人都纯友谊。
我觉得我身为一个男性，正常的，不要，我觉得我不正常。但我的意思说，对，如果一开始我认为这好灵魂拷问，就是好，我认为他是纯友谊，他也认为我是纯友谊，但没想到发生一个意外，必须要睡同一张床。说实在，我的选择会是我在旁边地上铺，但是我又会觉得这个举动似乎又更尴尬一点，所以我会很矛盾，就是
怕对他又更不礼貌，因为你不知道他怎么想。
就是反而我自己睡地上的铺个垫睡地上的时候，反而更暗示了我好像不能跟你睡同样。
没有啊，你们猜拳啊，输的人睡地上。
好，但我的意思是说，如果好房间就这么小，连地上都没得睡，只能睡同一张床，就这样。好，我觉得
地上都是虫，
我会蟑螂。
蟑螂超多，
这是订饭店的人到底是谁？好，我会觉得有，我不知道故事会怎么写，故事会怎么走，但是你说那一对人有没有可能变化？有可能，但当他变化的那一刻的时候，我会觉得其中一定有人不是用纯友谊的心态在看。
所以觉得2个都是用纯友谊来看，就不会发生变化。
你看你的娃娃从这个上面倒下去你暗示了什么？你知道吗？
跌落神坛。
你来死对不对？但对啊，因为如果真的就是很纯，就睡觉，然后各自背对背睡也 OK 啊，就是
翻身吧。
但是如果会启动，那就是不管是一个人有那种心态，还是2个人都有那个心态，就是一戳就破了嘛。就是那个东西，就是你一直说纯友谊，说到最后，妈根本不是嘛。对啊，他就是这样啊。
没有可能就是那个时刻啊，有了些什么，但之前都纯友谊没错啊，这有可能吧？
我不相信，这种我不相信。
你不相信吗？
我不相信。
我相信啊。
对啊，有可能吧？就是本来2个人都纯友谊，然后就是在那么亲近的状况之下，忽然有个什么东西就忽然的噔，
没有，
就像龙猫那里面，
我其实没有要挑战或你们大家要相信什么都可以，只是我是说我的确不是这样。我会觉得，如果是你刚刚假设的情况，对我个人而言，我会觉得，这就是一开始多少都不是那么纯友谊啦。我自己的心态是这样。
但如果我看待那段感情是纯友谊的话，我
真的就会说，哎，尴尬，不行，我们还是再另外找一间房，至少分开睡。
那很妙吧？所以我自己会觉得，
不是不管纯友谊跟男跟女都不想睡同张床，因为我觉得跟朋友睡同张床超奇怪。
我觉得睡觉就是要自己一个人睡最爽。
对啊，如果不是伴侣的话，睡同一张床，我会自己睡得非常不好。所以即便我觉得我跟他纯友谊，
所以你宁可醒来了啊？你宁可醒来？
我躺在地上然后爬拍。干，换你睡地上。没有，我可能真的会，要不就睡得很边边了。但是我觉得是有可能，我想象中，的确有这样是 OK 的人。
你是说本来是纯友谊，但是真的不小心在某个状况里面打一炮，然后之后继续纯友谊？你是说之后继续纯友谊吗？
那也是有纯友谊啊。
对，也是啊。
打球朋友一样啊。
那叫纯友谊好不好？啊，那叫床友谊，那不叫纯友谊。哦 ，OK， 不太一样，念法不一样。
去动物园看猴子的那种朋友。
来。
然后坐起来了吗？看到猴子看一看，然后就坐起来。
叫猴友谊。
OK， stop。我觉得我们不要再拷问他，我现在要拷问你。
没有，你们刚刚凭什么认为在拷问我？
因为你觉得我们在拷问你啊，你自己刚讲的啊。
没有，我只是说那个话题对我来说是灵魂拷问。
我现在要救你，你给我闭嘴。
救我？刚刚有什么好救的？
啊，不用救吗？那我们继续。
没有。
所以，
我刚刚做了一个什么样很糟糕的示范嘛？
没有啊，
你
只是很挣扎而已。
我是怕你对你感觉压力很大的样子。
对，你是很挣扎。
因为我会就跟你们好像想的不一样。
没关系啊。
我觉得纯友谊，但我也蛮好奇你们说的那个样子。就一开始认为纯友谊，然后就让他做一下，然后他继续可以纯友谊，很厉害。
没有之后能不能纯友谊不知道，我只是说那一刻有没有可能会变质了。对，就是那个时刻。
对不起，你这会变质，讲
然后隔壁一直
讲超级生理的好了，讲超级生理的。
左右夹攻，
这是非常肤浅的一个切角，就是我会想要跟他发生关系，或他会想要跟我发生关系，两情相悦的情况之下，也都是因为对方的外在一切都还看得上眼嘛，对吧？
然后呢？
不是，我说对彼此的电波，我的意思。对彼此的电波，外在电波是类似的吧？
小萝卜到你，小萝卜到你。
等等，这话题很危险吗？
你不可能跟小萝卜有纯友谊的，不可能的。
等等，我刚刚话题很危险吗？
没有啊。
对啊，我是指
什么年代了？
生理的需求，还是有一个各自的。
对不起，之前是生理需求，
就是有各自的门槛或标准在吧？
对啊。
那所以他，不会因为突然就质变了。
哦，你说做就做，但不情感是不会质变的。
没有，我是说，
没有，我觉得这也没有什么，就是就做了嘛，但是其实情感不会质变的。
不可能啊，我不是这样。
我做了就是会质变的意思嘛，有可能会质变。
对，而且我站在的想法是觉得一开始就不是那么纯啦，我还是这么觉得。对不起，我自己是这样觉得。如果是我出发，我就说了嘛，我就说我们可能以为纯，但其实其实不是一点都不，而是其实也没有完。如果到可以
来我一直以来的这种
可以到因为可以到身体接触，我觉得它就是一个很大的，那不是质变的问题了。你说如果不小心牵个手，在躺在床上牵个手不要这样比较好。然后我觉得我不知道，就是我觉得到可以身体接触是完全是另外一回事，不可能从纯友谊质变成纯友谊，质变成可以身体接触发生关系。我觉得这一个关键不叫质变，这个关键对我来说前面已经有
叫阴谋，
不是，前面已经有一点什么了，但是那个什么可能很低，非常低，但你不能说是零。
跟病毒数一样的感觉
对，测不出来，
超过
很漂亮，对，因为你不可能做那样的选择。
这可以发表期刊呢，
期刊、科学期刊、医学期刊，
可以写个论文的。
在《柳叶刀》上面你要发表一下，就是人的情感像病毒数一样的感觉。
我会那么认真的想要回答，其实只是因为我觉得这个问题很有趣，然后我也遇到的时候，我会想，在我个人，我会真的能够很坦然的说出纯友谊吗？我好像很蛮难这样。我是说在那种状况，但你说我人生中有没有纯友谊的对象，我认为还是有的。我的意思是这个。
可我觉得随着年纪越来越大，越来越有可能可以说出来。
可能性的欲望也降低。
荷尔蒙
对，荷尔蒙降低。
真的吗？我睾酮数目前是933。
因为 真的，我戴一下我的眼镜。
爆掉。
你也搞榕树是不是？
但我想要问，可是我想要问阿达，
谁的 watch 会监测你搞榕树了啊？
我说他说我上身了，我不用接这种电话，我不用接这种电话。
但是如果说
我想要问阿达啦，因为刚刚都 focus 在你身上。
来，好，你问我。
我们不要再攻击你，我想要问你，
对，
你觉得你的纯友谊可以做到什么程度？
你刚刚说饭店嘛，那
我可以跟他一起出国
，2个人而已，
两个人一起出国，睡同一间房间，睡同一张床，然后我会开始慢慢怀疑我自己。这个时候我怎样？
你要上网查东西，
我要上网查东西，
你要上网查到底这样的关系是什么？
这种时候绝对不能断网。如果饭店 WiFi 又很慢，不能用怎么办呢？
怎么办？
你需要 Steady eSIM。
Steady eSIM 是一个非常好用的一个，
真的好用，
需要这个啦。
现在呢，实体的这个 SIM 卡呢，已经慢慢的不是那么适用了。
对，因为相对来说比较麻烦一点点。
eSIM 很方便。
你想看你在床旁边
，SIM 卡，
对。
你那时候如果要换实体 SIM 卡，多尴尬啊！
对，你想想看，你睡在他旁边，然后你要换 SIM 卡，然后你要拿那根针一直戳，一直戳，一直戳。对，然后稀稀疏疏的，
这听起来有点心寒。
对，稀稀疏疏的，他可能会觉得你怎么了这样。
对，但是不是你只要换 SIM 卡？
所以用 eSIM 是很安全的这样子。
对，而且Steady 的 eSIM 它是只要安装个 App 之后，它会自动帮你安装你的 eSIM，所以是可以直接用的。
而且不止直接用，你下飞机以后，基本上它就可以自动搜寻，只要设定好以后，自动就开始搜寻。而且最重要的是，如果好比如说你去欧洲的地方，你在从一个国家，常常我们不会只去一个国家嘛，你从一个国家到另外一个国家，其实你完全不用再安装别的 SIM 卡，或者是就是同一个，然后它就可以无缝接轨过去。对，
而且要分享一下，我们这次去大阪工作嘛，之前那个台湾文化世博，我们有去工作，然后之前其实我们团队就是大家都要买，就是 Steady eSIM，
对啊，
然后就来问大家每个人各自，反正每个人要买10 G。我觉得我用不到那么多了。
阿达觉得他用。
对，我想说 Steady eSIM 很方便，所以我买了之后，我买5 G， 我要加我再加。后来发现我果然用不到那么多，所以一开始如果我很害怕，如果我买不到那么多，我加卖麻烦的话，我就会买10 G，那剩下那5、6 G 就全部浪费掉了。
因为我是一个人自由行嘛，因为不在工作，然后我先买5 G， 我也是怕说太超过，后来我觉得好像快要用完了，那我就赶快再加买个3 G。结果我发现旅途结束之后，我没有用完那5 G，所以我就退了那3 G， 结果退成功。而且你知道吗 ？Steady eSIM 还有内建那个 VPN
啊，对，
所以因为有时候我们出国的时候就很难连上台湾我们想要看的某些东西，因为它整个 IP
就是台湾的这个 IP 位置，
有这个功能之后超方便。
看台剧啊、购物啊，即便是台湾用台湾的网络购物也是。
而且说也是网络安全的问题啊，因为 VPN 它是用虚拟的 IP 嘛，所以就不会让人家追踪到你的 IP， 你刷卡啊、认证什么东西都会方便，对安全非常多了。
对啊 ，Steady 是 Nord 嘛，对啊
，NordVPN，
对啊，因为我本人也就是用 NordVPN。
哎呦，
对，所以其实我蛮相信的，因为我觉得蛮好用的。
而且我觉得它的价格真的算便宜耶，因为以前我们出国，我们可能就很担心，就买了一个那种 eSIM 卡，然后但是可能20 G 这样子，然后那个价格大概就是几千块，但因为现在美金又很便宜，
也不是说很便宜，台币强势了一点这样子。
就是汇率现在来说，美金对台湾是友善的，所以因为它是用美金付费嘛，所以相对来说现在买是非常非常划算的。所以最近有要旅游朋友呢，认真推荐我们的 Steady eSIM
没有错。然后因为是我们在推荐，对，所以大家如果想要购买看看，刚好要出国的时候，想要试用看看的话，可以在它的那个折扣码的部分，输入一个 COME。
85折的优惠
，85折的优惠。对，那希望大家可以试试看。那我们都觉得体验很不错，然后分享给大家这样子。
认真推荐，认真推荐。对，那就是我那时候用 Steady eSIM，
我们第一次是冲绳。
对，第一次冲绳
第一次使用是冲绳计划。
我说真的，我用了就回不去了。
真的很
真的，那个 app 就一直留在手机，然后每次出国就开始去，而且都装好了。
而且有容量焦虑的人，就是不是容量，就是这种
我其实是
对流量焦虑的人称得很好用，一开始知道剩多少这样子。
方便。
对，那总之去用吧。对，那其实会用 Steady eSIM 的人，我也是有纯友谊的可能性的，这样子。
至少你可以查你们是不是纯友谊，你可以问你的 ChatGPT 说我们是纯友谊吗？
我很好奇 ChatGPT 会怎么说？以你的线索，然后最后他可能回你说 这种问题你自己都答不
上了吧，老哥。
对，
他回你这个，
你在开玩笑吗？
好了，回到我刚认真做一个结论啦。
对，
可以，你可以结论了。
真的可以出国吗？
我觉得一起出国 safe 没有问题，我觉得2个人住没问题，但是住在同一间就不好。
你说同一间房还是同一间旅馆？
同一间一定同一间旅馆，不同一间旅馆多麻烦呐你！不要一起出去玩的，好麻烦啊！
真的哦，但我觉得
不要同一间房，因为不要同一间房，原因也是因为我本身现在就是不喜欢跟人家住一间房。
我也是，
我们都习惯单间了
啊，所以我跟人家住一间房，这也对我自己也非常奇怪。如果跟人家交朋友的话，所以它其实是一个反直觉的东西。但是说最极端状况，就只订到一间房的话，没有想不到其他办法的话，我可能就睡地板，或者是我就去外面闲晃。
我一定猜拳才会决定谁睡地板。
我可能就出去闲晃，那天晚上我可能就真的没什么睡，因为我知道我也睡不好。
你会去那个吗？飞田新地嘛？
哎，我跟你讲，
最近没有开玩笑的，
他们
我查过。哦，他们纯，
你居然突然开一个这样的
什么别
人的这里？
没有，因为还有网咖什么的啊，网咖可以睡啊，只是不是旅馆啊。对啊，
所以我最后我会觉得说，反正这个问题是放在不同的状况里面的时候，其实你要 care 的事情不一样，然后对象的不同，然后启动那个你要跟他就是想要认识这个人的那个出发点不同，其实都会有不同，对象不同也不同这样子。所以你说有没有纯友谊，我个人觉得可能有，但是能存到最后，这也不知道。
那只有在人生的最后才会知道这件事情。我死之前，我跟这些人真的是纯友谊。然后下一题，如果可以，我要在这里写500字心得，说我爱你。女性31到40岁，大咖咖你们好。作为一个资深店员，常常为了跟同事沟通方便，会帮客人取一些绰号，像是感恩阿姨，因为一直说感恩；白发大姐是头发白得很漂亮。如果是在操场，可能会有烟品系列的大哥大姐。想请问大咖咖觉得自己或对方会被店员取什么特质记得呢？
自己吗？
对，我们
不同哥哥吧。
然后你们8月负责忙碌养好休息哦，记得快乐哦。人家在祝福我们，听我讲，人家祝福我们很重要。你们8月顾着忙碌，也要好好休息哦，记得快乐哦，爱你们。
谢谢。
当我们在说人家爱我们的时候，一直在那边搞固同哥哥。
搞固同哥哥也需要爱的啊，没有爱哪来搞固同呢？
超需要，要爱也要做，好不好？
搞爱。
傻。好，会有什么做？因为店员嘛，我觉得不同程度，一直去买的那家早餐店一定有不同的，因为认识了嘛，可能知道比较多。但每次只是去 7 结账那种，可能又是另一种。我们先讲外表好了。
他通常应该会是那种吧，很高的那个来了。
没有
没有哦。
不是，我记得我被记得的是那个要脆一点，或者是那个辣，那个要加辣。
你很鸡掰
要加辣的。
那种加注的，
我知道，加重加辣那个。
对啊，鸡肉面一定是啊，对啊，对啊，兰迪阿姨、柜台阿姨应该有记住啊。有，哎，这个故事我讲，
你叫桃啊？
不是啊，
对，他们就说桃啊。
对啊，他们坐在外面休息的时候，因为我都不是中午去吃，他们会记得我。但是我要跟大家更新一些消息，就是兰迪他们会换员工，因为阿姨也有她人生规划，所以很不幸的就是有一些阿姨。他去做了可能更开心的下半辈子的人生规划，所以可能我最喜欢的那个阿姨，不在我喜欢的那间店里面，然后来了一些新的阿姨，然后她没有做给我吃过，然后不对，那不是我，
好伤心。
树欲静而风不止。
不是，我是说他过他开心的下半辈子，为什么要讲那么恐怖的事情？没有，就是他们好像有点异动。就是我没有吃到我喜欢的味道。
你的眼角有泪水？
没有泪水啦，就是我甚至我心里真的想过，就是我去打工一下，我就是学1个月就可以离开。
你刚才也不是纯友谊哦，你知道吗？
不是啊。
但我觉得你们上次宣传也不算宣传，就是分享这件事的心得之后啊，好像有一点影响。因为那味鸡肉面啊，涨价了。
现在是150，我加大加重口味。
他们是不是发现各分店这个购买量提升？
当然应该是整体降价，因为他有写啊这些。当然我要呼吁大家，就是
大家喜欢吃吃看我们的生活的吃过的东西，然后跟大家分享没有关系。但是如果大家太被我遇到的时候，其实我会害怕，我不太想在我这么自在生活的地方遇到那么多次，
压力会大，
真的压力。
真的。
对。
我上次我们一群人也在讨论说我们喜欢的某一家跟另外一个朋友剧组朋友们，然后我们喜欢的是哪一家，然后我们也开始担心说，会以后很难订到位。
哦。
对，都会担心这一块。
所以他们会叫我重咸哥哥，没有错。
真的单纯只是点餐上的关系吗？
合理吧？那些南里的阿姨就会说是重咸哥哥吧？
我可能叫你拜圣。
重
拜圣哥
，spicy 哥哥 ，spicy， too hot， so hot， 这样
，heavy bro， 很 heavy 的那个 bro。
那你呢？你会怎么叫？
忘付钱吧。
哦，真的啊？
没有，有时候早餐店忘记。
真的啊？你好过分啊！
我还滑手机的时候忘记结账。
那他会怎么说？哎，
我报警了。
报警哥。
没有，偶尔很少。
报警弟弟。
你说对我会是什么？
对，他们都会叫你什么？不要跟我说帅哥哦。
你白发吗？不是白发。他会，我觉得他不太会，我觉得他会说圆圆的，圆圆的。
高额吧。
高额。高额有点这个词汇有点不直观嘞。眼镜哥呢？
我之前的确有听过，就是矮的那个。真的，我真的听过。就是那杯可乐谁要的？
这比杨贵
矮的那个。
杨贵老师，
因为
被说是那个。
通常我一群人当中，最好标示就是矮的，所以他们说送给谁或怎样的，我觉得一群客人当中，矮的那个弟弟，
坐着都一样啊。
矮的那个弟弟，等一下，弟弟有回来一点哦。我觉得弟弟这个部分，他有试图帮他。
矮的那个弟弟就绝对不是你，你不能拿他的早餐，一定另外一个是矮的弟弟。
现在弟弟都比我高，蛮多弟弟都比我高。
但是弟弟跟身高无关啊，弟弟跟容貌有关。本来就是啊，谁哪我必须要诚实。
我对阿姨来说都是弟弟啊。
哇发，
阿姨是姐姐啊。
好惨哦。
我是弟弟啊。
你要确？
没有
确定呢？
好，那一家是对，其他早餐店我不敢讲。对，但那一家的确是大姐。
她做早餐的时候假牙没有掉出来吧？
没有，他有一个那个链子挂在这地方，夹在这里啊。
矮的那个弟弟，他是这样讲。
哇，所以你会
矮的那个比较容易啊。
好啦，谁拿真的没有什么好说的，也有可能叫我鼻毛哥啊。
哦，有可能吧？因为他比
你是看老板的。哪里？
啊，那个未成年的。
这也太爽了吧！
这样是爽的。
对呀。
那如果是那个短发弟弟，
其实常常。
真的。
我还有进过厕所说，先生这也是女厕
哦。被人家说。
捷运上被说不能。
所以阿姨会跟你说，先生，这是早餐店哦，这样哦。
他点的什么？辣味鸡肉面吗？的确被人家讲哦。
下巴妹之类的会不会？
怎么可能啊？大家怎么把这种绰号想的都这么攻击啊？
没有，我就说可能背后，我们在讲背后啊。
我知道。
他不会是当着你的背讲。
黑色
42。
这个是很明确了，好不好
？42号。
一定跟他们讲42，哎，42来了。
有可能，47有时候会被人家说。
对啊。
很明显吧，42。
还有呢，G2 妹。
G2哥，
老板在潜水是？
带着 G2 的表。
懂哦。
但是你常常穿全黑的，我觉得黑色的，我会有说，那个比较阴沉的，对哦。
这还蛮适合我。
或者是阴暗仔
的石英法师这样。一直贴很奇怪的表情。
穿很宽的，有没有可能？
看起来有点像精灵的。
哇哦！
你今天才考他？
没有啊。暗黑精灵。
为什么补了这个？
暗精灵有一种精灵。
加了一个这个暗精灵。
你才是甘道夫吧？这样的话。
而且我甘道夫很开心啊。真的。我会说那个蛋饼 should not pass 这样。
那他就不会给你啊。
我是重做
不合格，
原不合格。
天哪！
优秀的 pass。
这 是高等拉姆齐吧？
但这样讲很失礼，但我真的不想讲，但我还是讲出来好了。哥布林，
哎，你不能这样，不能这样。
对不起，
阿达，阿达，
我不了解这一块。
为什么
抱歉
阿姨会知道哥布林？
阿姨是转身来的、啊，她是从异世界转身来的这个世界的早餐店阿姨。
好强！
看到
是不是？
我们这世界也有哎。
没有，他不会这样，他的过去的方式，沟通方式就出来了。
但我们私底下很难被取外号吧？
不是啊，他就是看标签嘛，比较好喊啊。
不然你为什么喊犬？
犬，哇，你真的把炮火往外。
犬哦，那个短发妹妹啊？
对啊。
妹妹，妹妹头妹妹。
哦，我知道了。
哎，毕业了没啊？
没有啊，这是问句吧？这是问句吧？应该是说达康小编吧？
那我们不就被叫达康而已吗？是有差别吗？不一样的事情吗？
但是好，先以妹妹、弟弟来看，犬、哈利、艾莉绝对可以叫妹妹。
对啊，
绝对会被标妹妹啦。
对啊，
但是我们两个绝对不会是弟弟啦。
真的是阿伯或大叔。
不会，我觉得他们都会叫弟弟。
哦，撇除了早餐店，
你带我去你那间早餐店好不好？你带我去，我们不要讲哪一间，你带我去。
你穿这样，他可能叫你，哎，大哥。
我想，我那天穿的非常老成，我看他会叫我。对，穿西装
都不会，
穿西装不会。好，
穿西装就是先生。
那我穿附近这个顶溪国小的，反正就是类似那样的。
你会被抓了，不要这样。
变态，
没有，
变态来了，
你会被
变态来了。
报警哎。
哎，现在小朋友发育很好啊。
太好了吧？
我是买全新的穿，我又不是去顶溪国小门口要，哎，你身材跟我差不多，我怎么可能啊？
你有看过？你有看过《让子弹飞》那部电影吗？里面不是有个8岁的吗？你就是那个状态，如果是这样的话。
但我是说要测试看，我被叫弟弟太不合理了啦。
没有穿普通衣服，没有真的，他们真的叫你弟弟啦。
叫我弟弟？
你那边的早餐店阿姨到底几岁了？
哎，你可以叫我一声弟弟吗？
弟弟，
合理啦，对，你呢？没有，因为是姐姐还是说什么？
你有点让人不爽。
对不起，我选错了。你认真的说，哎，弟弟来一下，
弟弟来一下。
为什么是弟弟？为什么是四声啊？
弟弟，真的叫弟弟的感觉。弟弟，
好变态啊！
弟弟。
啊，我知道，如果在。
弟弟来一下，
弟弟啊，阿弟啊来，阿弟啊来。
手势影响很大。
这个部分叫我弟弟，我 OK。
啊，那我一夸起来，
完全合理。
阿姨厉害哦。
对啊。
阿姨
也要18招哦。
阿姨的第一招。
这是什么？
阿姨的第二招。
后下哈。
阿姨第3招。
龙山18掌。
不会，你应该还是有被叫弟弟过啦。
对，我没有印象，我会叫帅哥。我想认真的，我遇到的都是这种。
所以他们是因为不愿意叫。
然后他就把不知道啊，他就把早餐的那个外带袋子拿出来嘛，哎，帅哥，然后就5只手手
我才是帅哥，我才是帅哥。
哎，我们上次走在哪里呀？然后路上有人叫帅哥，然后他回头哎。
等一下，
我们没有买东西哦，他回头了。
好糗哦。
然后他说他以为什么东西掉了。
他给了一个借口，是不是？
对，他说，我说你刚是回头了吗？
好糗哦。真的啊？真的还好
我不是觉得。
回很快哦。走，然后帅哥，然后就回。还犹豫了一下才问他。
哎，你真的相信这个世界上有纯帅哥的这种人吗？
没有，我是觉得那个声音的方向性很像叫我，因为我以为是我怎么东西掉了，
所以
因为有人就是会很习惯叫别人帅哥，因为他不知道叫你什么时候啊。
所以所以你是认同帅哥不是方向性吧？
不是，是有人在叫我，不管他称呼什么，哎，我也会回头。
究极，
究极太明确了，他们这个 通用词。当如弟弟，我也会回头；先生，
弟弟你也会回头。
阿贝，
叔叔，我也会回头。叔叔，我也会回头。
真的。
废话。
但帅哥回头真尴尬，因为我们没有吧？我跟你讲，我听到我后面有人叫我帅哥的时候，我都是
你想回头对不对？
我会控制。然后当他叫第二声没有帅哥，我还是会这样。叫第三声的时候，说你啊，帅哥。对，就你哦，怎么样？我会让他暗示到我有一点赞。
犹豫，但你犹豫。
我会很谦虚的在接受这件事情。
我会练习，不要帅哥的时候回头，好吗？
那你要小心，有一种状况真的是不行，就是这样，帅哥，这样就一定要快回头闪开。
那个不用回头，闪开就好了。那个不要回头了，赶快闪开。
但我到现在都还记得，因为我们就在那边的巷口。
好啦。
然后就帅哥，然后就。
阿达的脸是这样，我记得就是那种。
我没有，你们没看到。干好恐怖啊！
怎么了？自己是帅哥。
我又不要跟你们走在路上。人生一次 miss 就这样。
拜托以后观众如果在现场看到我们，或者你在路上看到我们，叫帅哥。
一失足啊！
没有啊，
我那次真的是回头出来发觉
不对，自己不是，
不行，我这时候回头太不要脸了。但是我回头了。
你回超快。
还有目击证人，因为那是反射动作，就很像早餐店阿姨在叫你帅哥，你要看一下是不是自己的菜。
而且我们就是买完，从别的地方买完东西回来，所以没有道理会有别人叫我们停下来的。
不一定啊，所以我什么东西掉了啊？
头发哦。
你今天恭喜指数很高等一
下，我说认真的，在这里我跟陈彦达郑重的道歉，我觉得我刚才的话很过分，对不对？
是啊，有点过分
我现在对你只是纯友谊哦。
你确定吗？看我的手肘。
说真的，纯友谊还算对他很原谅了。
哦，真的。
对。
我现在视你如粪土。
笨友谊。
我以后不会在你面前，我在你们两个面前都要加倍小心。
真的
不会啊。
恐怖了。
没有啊，我会跟你一起回头的，好不好？
哦，不错，兄弟。
我们一起回头，看他说哪一个，然后就两个都不是。
绝对都不是的嘛，应该叫别人嘛，就跟那种路上人家这样，然后你跟他说，就他叫你后面那人是一样的道理。我常遇到这种。
的确，因为他很容易越过。
没有，因为好，我们现在这状况是的确有观众会。
对，有时候会认出来。
跟我们
对，
所以我就有一种，有时候人家这样
就礼貌性的会，
就要跟后面的人打招呼的时候。
那你会维持那个脸继续走过去？
我就会追在后面。
然后后面那个人也误会。
对，就一个连手。
一整条街都这样。
大家都在想人。
有人说帅哥，
像锦鲤一样。
哇，这个话题是什么呢
？Oh my god！我们会被叫什么？
我们会叫什么？
刚刚说过了啦。
陈达就帅哥了啦。好。
对，我觉得帅哥不可以。跟你讲，真的喜欢，好尴尬哦，真的很尴尬
我要付你门票钱。
一点都不帅的，然后一直被叫帅哥，真的很尴尬
没有我觉得被叫帅哥，即便是不帅的人，他只要回头的很帅，我都会觉得他的气是帅。
他回的很帅。
对，所以我是说，
阿力，你们有造谣？
没有，我的意思是说，这没什么啊，就是你只要对自己有点自信，又有什么关系？
我没有。
是有弧度的回头，那种，你知道那种感觉？
我懂。
刘海是一定会帅。
我学一下。你是说，比如说镜头在那边，然后被叫帅哥的时候这样？
对。
这种速度吗？
但行云流水，更快。我跟你讲，他是这种，叫我。
那个。也是。
我没有这个脸，好不好？我没有这个。我没有model嘴，好吗？
梁朝伟的那种。
那如果是这样，帅哥。前面还有一排这样，可以吗？
很久没有人这样叫我了。
但是这种感觉，
这个我都比较能接受。
你这样很气质帅，真的。
被你们攻了，
你刚刚说他什么？
我跟你已经纯友谊了。你现在就晒，我跟你讲。好， 啊，其实差不多了，
差不多了，
前面差不多了。好了，我们这个 QQ 呢，欢迎大家投稿，好不好？
对，欢迎。
有很多很有趣的问题，像第一个，哇，我们纠结很久的这个问题，
纠结蛮久的。
对，然后第二个问题也是，哇，被挖出一个黑历史。这样，好，希望大家可以多投稿，然后我们也希望可以回答大家更多的问题。是的，那如果呢，想要出国的话，最近美件便宜 ，Sally eSIM 很方便，请大家一定要使用看，因为我们真的一直有在使用它。
对，就使用下来了。
9月带家人去旅游，我也会用 Sally eSIM，
没有错。
扫描 QR code，然后这个 COME
是的，大家要确定自己能用 eSIM 哦，因为有些手机的确不能用。要确认自己，因为
他记得 iOS 和那个 Android 都有。
因为我妈是比较旧的 Samsung， 发觉没有办法用，因为没有 eSIM 系统，但其他都可以。
现在手机基本上这30年都有 eSIM 了。
对，所以大家要注意一下手机能不能用 eSIM 哦，然后那个规格合不合？那我合的话，真的非常非常推荐。好的，那如果喜欢我们的影片的话呢，请追踪订阅我们的 YouTube 频道，而且开启通知。然后还有我们的社群 IG 啊、Facebook 啊，都欢迎追踪。那我们会员频道 YT 的会员频道也有更多好啦达康的影片可以让大家看的，包括整场演出都会放在里面。
不只是台北场或者是新十一场，有其他场不同的内容也会放上去。然后欢迎大家真的很喜欢看类似这样的喜剧的即兴的也好，或者是漫才，都欢迎加入我们的会员哦。
是的，那我们现在正在好啦达康的巡回当中，这是很特别，是跟漫才少爷一起的。对，因为哈利他请假，他去演那个 Reality No Show。
对，
我可以打广告吗？
可以。
8月28号到31号在台北表演艺术中心的球剧场，欢迎大家购票来看。
前面不用讲那么卡，球剧场台北就只有台湾就只有一个球剧场，
很明显，很明显。对。
好了，那我们这次我们现在应该巡演到在台中场左右吧。好了，达康。对，那如果还有票券的话呢，欢迎大家可以一起来看。对，我们第一周演完，只能说真的是挥洒我们4个40几岁中年大叔的这个热汗和热血啊！
演完变成风中蟾蜍。
对，真的很希望大家来看一下。
风中蟾蜍，
这不是有这个冷笑话吗？
你是真的在讲一个笑话。台风天的蟾蜍真的飞在风中，还真的是。
但我没有说，谢谢。
好，希望大家可以多多参考一下。好，那我们今天答案就到此结束，大家拜拜。
拜拜。
怎么你的 size 啦？
好了，这个环节是什么呢？基本上就是一个吹牛的游戏。那大家进场的时候填纸条，上面填一个物件啊，就关于食衣住行啊，任何一个没有形容词的物件。那等一下呢，我们就用这个物件来进行吹牛。在吹牛过程当中呢，有2个人是知道这个纸条内容，有1个人是不知道。然后这个人呢，就要负责猜到的东西是什么，以及抓到谁是说谎
啊，没有错。
那等一下我们计时2分钟，在前30秒的时候呢，是不能够说谎话的。
前30秒不能说谎。
然后30秒响铃之后呢，后面就开始可以随便要说什么谎都可以了，就要开始抓了。
猜的人可以选择抓，也可以选择猜到了。
没错
，OK。
请帮我抽一出康康今天的这个要猜的物件是什么呢？来，不用删，还没有抽。
好啦，为什么要笑？盲猜哦，你不要闹哦，前30秒不能说谎。
不可能哦，真的不可能。说实在，我觉得你的字典里面根本没有这个。
稍等一下，稍等一下，我先确认一下。这个是符合规则的。
符合规则，超级符合，超级符合。
OK， 我超出这个观众。
好，准备好了。Ready， start。
炮房
炮房，
算是一种炮房吧。
算可以这么说。
炮房，等一下，30秒不能说谎。
这么说吗？
是吧？
为什么怀疑了？
广义来说可以。
我有说谎吗？
广义来说可以。
炮房可以打炮的地方，对，可以打炮的。好，
要打炮就算了，还有别人在帮你。
真的。
这不就是那种地方吗？
我跟你讲，这地方专门外带的。
什么啦？
就出场啊，
而且
30秒了，
好野外哦。
好野外
，30秒了。
我要猜。
好，请。
酒店，完全。
以你的思想是绝对猜不到这个东西。再见了。
等等，我再确认一次，炮房。
对。
有人帮你，然后还可以外带。 请继续。
而且它有些很香，
很香。
对。
空间吗？
有些很香，有些很臭。
对，但有时候真的会过敏啊。
也没味道的也有。
暂停，我要抓。等一下，过敏。
没有说谎。
超级没有说谎。
对，超级没有。我觉得我方向是错的。
哦。
哎，对，我知道。当你讲酒店，我就知道方向是错的。
可以继续啊。有香有臭，可以过敏，请继续。
还有1.9了哈。
你有舔过吗？
我吗？
谁问你？
我不知道啊。哎，
没有，但是我真的是上厕所没有的时候，我拿来擦屁股。真的会过敏，真的会过敏。
我不确定他有没有说谎。
跟我抓！
啊？抓什么？
你根本没有用它在上厕所擦屁股过吧？
对，谢谢你。
好，大家安心了，大家安心了。
对，我没有哦，谢谢你抓我这个，不然我没有机会澄清我这个谎言呢。
请继续。
我好担心哦，
而且它的本体常常有很多歌曲会去赞